Meeting this interlocal government workshop to order at 9 a.m. At this time, I'd like us to stand, and if you would please join me in the Pledge of Allegiance to the flag. I pledge allegiance
to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. On behalf of the Indian River County School Board and staff, we would like to welcome all our participants and attendees this morning. Today, two of the largest employers in the Indian River County will be presenting the do's and the don'ts and best practices in managing a cost-efficient, self-funded health insurance plan. And they are the School District of Indian River County and the county, Indian River County. First presenters on the agenda is School District. The school district employs approximately 2,100 employees and has approximately 1,860 enrolled employees, subscribers, not including retirees in these numbers. Presenting for the school district will be Aon, our insurance consultant, broker since 2016, and CareHere, the school district manager of the Health and Wellness Clinic. Second, we will hear from Indian River County Administrator Jason Brown and County HR Director Suzanne Boyle. Indian River County employs approximately 1,300 employees with approximately 1,600 employees and retiree subscribers. In having this workshop today, my hope is that we can learn from each other, cost savings, tips, and strategies. I personally see that the school district and the county has one growing issue in common, and that is the fact with limited revenues, as our cost of providing health insurance increases, our ability to give livable wages to our teachers, police officers, EMT, firefighters, and employees diminish. I look forward to finding solutions to a complex issue with this panel filled with talented individuals. I'm going to ask that everyone save all their questions until the discussion portion of the workshop, and everyone has at their seat. They have the schedule here, so we will have a break approximately at 10:45, and then we'll come back, and then we'll open it up, and we'll start our dialogue. At this time, I would like to quickly go around the table and have everyone introduce themselves, and I'm going to start here with our guest. To my right.
All right, thank you. Jason Brown, County Administrator for Indian River.
And I was asked by our IT to make sure we have 12 microphones, so when you do speak, to make sure that you try to speak into the mic.
Suzanne Boyle, Human Resources Director with Indian River County, Board of County Commissioners.
Paul Carlisle, City Manager, City of Sebastian.
Colleen Boyer, Human Resources, Sheriff's Office.
Laura Turner, Director of the Support Services Division, the Sheriff's Office.
Tim Zork, County Commission, District 3.
Joe Flesher, County Commission, District 2.
Diana Bays, Director of Clinical Services, CareHere.
Patrick McIlerney, Business Development Lead for CareHere in Florida.
Lacey Gallagher-Marsh, Senior Director of Operations for Florida, CareHere.
Good morning. Paul Booten, Aon, Tampa.
Good morning. I'm Jeff Jinks. I'm with Aon Health Solutions.
Lucy Antifiore with Aon.
Amy Eider, School District Employee Benefits Specialist.
Mary D. Mercado, Risk Management, Indian River School District.
Terry Barenborg, School Board Member.
Jacqueline Rosario, School Board Member, District 2.
Mara Schiff, School Board Member, District 1.
Ron Fagan, Chief Financial Officer, Indian River School District.
Susan Moxley, Interim Superintendent, Indian River School District.
Okay, thank you. And then we have our high-top members that are in the right over here. At the end, I do plan on, if we have time, I would love for you guys to, if you have questions, I have an extra mic, okay? Before I turn the floor over to Aon, as we try to learn from each other, I think it's important for me to highlight a few basic facts about the school district employee benefit plan. So if everyone would please take one of these. I'm going to give a recap, or very, very quick recap of the most recent information presented to the school board on May 14th. So I think this will help us as we're trying to look at the differences between the county and the school district. So if you would please turn to page 3, the health insurance Florida Blue. I did want to highlight the fact that the school district, we have 3 plans. We have a high plan, a middle plan, and a low plan. And in addition, we have, if you'll go down to the bottom, we have 4 tiers. We have an employee, employee and spouse, employee and children, and family. I believe the county has 1 plan, but they are going to 2 plans, so that's a different, those are some differences. And then the county has the employee and the family plan, or tiers. If you'll see, the board currently contributes $270 per member per pay. And then I think that's important to know as we're going through the workshop today. CareHere will review most of this information here, and so will Aon. So I want to skip ahead, and for those that are interested in the financial update on page 9. So currently, our ending fund balance as of June 19th is $4,298,000. So those are key points to keep in mind as we're listening to the presentations. Let's fast forward here to page 12. A historical comparison of health fund revenues. I do want to show you that our fund balance amount in 2015 was a negative $504,000. September 2016, it was a negative $4.5 million. And as of February 2016, on this presentation, it was at a $4.1 million. Fast forward to page 16. 2019-2020, our fund projections. We have approximately 2,100 employees, and we're estimated to have 1,861 employees enrolled. It was brought to the board just this past month to increase our insurance by 6.2% through our, but the board did come to a consensus, and we approved a 5% increase in our health insurance. So I just wanted to make sure that we had some of the basics of the Indian River County School District before we dived into our presentation. So at this time, I'm going to turn this over to Aon. And do you have the clicker down there? Okay.
I do.
So I'm going to pass out your information here.
Mrs. Zork, if I can take a moment, please, to provide some further clarification. On page 9, you'll notice a difference in the color of the type, literally of the font. Our fund balance as of the end of April was $4,071,033. The following numbers are projected through the end of the plan year, ma'am. Those are not actuals.
Okay.
And for those of us with numbers, that's going to be a little significance for us.
Okay, thank you.
Thank you, ma'am.
Thank you for that. So Jeff, if you will make sure that you speak into the mic.
Important safety tip.
Everyone have a copy? Good morning. Thank you, Chairman Zork and the board for inviting Aon to present on the rising costs of healthcare this morning. As I mentioned earlier, I am Lucy Antifury. I'm with Aon, and I'm in the Health Solutions practice. I serve as the account executive for the School District of Indian River County. Along with me are my colleagues Jeff Jinks and Paul Booten. I will let them introduce themselves.
Hi, I'm Jeff Jinks. I've been with the firm for 18 years, been involved with Indian River since inception. Lucy Ann is your account exec, but I'm strategic support behind the curtain.
Good morning. I am Paul Booten out of our Tampa office, group health actuary by background, a little over 30 years total experience, about 12 with the firm, senior account executive for a number of other Florida school districts.
And some of you may know Amanda Brooke Cross. She's been at the board meetings, and she's unable to be here today, and she is the senior actuary for School District of Indian River County. We know that we have a tight agenda, so we're going to jump right in. We will review broker consultant compensation along with health plan funding, specifically the pros and cons of self-funding, and discuss the reality with respect to cost and affordability and the strategies to manage the increased costs of health care. And we will review 6 pillars of an effective benefit strategy.
So this is more of a housekeeping item. We wanted to make sure we hit all the items you wanted to discuss. Broker consultant compensation, it's a cost to any entity. So much the same way we're talking about funding, whether it's fully insured or self-funded, an entity may want to consider, is it commission or fee? So I thought I would just walk through what these elements are. We can quickly knock this out and then move on. But any arrangement is going to start with the scope of services. In other words, what do you want that partner to do? From vendor management, marketing of programs, compliance, communication assistance, cost, actuarial, and so forth. So you lay out that scope, this is what we want you to do, and then it's just a function of what is the number, what is that amount that you are willing to pay for those services, and then it's either going to be paid directly by the entity through a fee, or it will be paid through commissions, which it gets built into the rates that are paid by the employees. So many entities choose a commission route in that it is not a fiscal responsibility to cut a check. And there's also, due to contribution structure with the employees, it is actually the employees bear some of the costs of their consulting services. What is important, regardless, because from our chair, we really don't have a preference one way or the other. It's just a function of what fits for an entity. But transparency is the big piece. And clearly, within a commission structure, you have to have that be visible every year when you do the marketings and see what those commission rates are. And the same is true relative to any fee and what our scope might be. So just thought I'd check that box and move off in case anyone had questions about that. And then we'll kind of move into the fully insured or self-funded.
So we're going to spend the rest of the morning, the rest of our portion of this morning's presentation, talking about really the main drivers of healthcare costs and the Aon point of view on how to best manage healthcare in terms of competitive benefits with managing the cost of the care and the trend of the care. But before we go into that, what we wanted to do was also cover a big topic. How do you finance a healthcare program? And there are really 2 methods out there that are largely prevalent. One is full insurance, where basically you pay the carrier, whoever your carrier is, a premium to fund the claims during the course of the year as claims emerge, and you basically shift the risk to the carrier for that year. Or the alternative method is to self-fund those claims. Let me just say right up front, for groups who are 500 to 1,000 employees or larger, your claims are your claims. So regardless of which method you use to finance the program, you're going to pay your claim costs at some point in time. There are definitely pros and cons to one method over the other, and our advice would be, eyes wide open if you choose one method over the other method. But let me just say, for larger groups, you're going to pay your claims, and then it comes down to what we're going to spend the rest of the presentation talking about, how best to manage those claim costs. So what we've done here is, and we could spend certainly more time on the nuances of some of this, is really try to boil this down into 4 major areas of what you get with a self-insurance approach versus a fully insured approach. And probably the most concerning one for employers as they try to make this decision whether to fund, self-fund, or to fully insured is the assumption of risk. And under an insured plan, as I said, you basically, with your carrier, agree on the premiums coming into the year, and we'll talk about in a moment how those are set, but then the carrier is at risk during the year. The employer pays the premium that's agreed at the beginning of the year, regardless of what the claims are, and that's what they pay for the premium over the year, and the carrier is then taking the risk during the course of the year. Now, with that said, if the claims are good, that good experience flows into the next year renewal. If the claims are bad, higher than expected, that adverse experience will flow into the next year's renewal. So under the insured plan, you have predictability during the year, but whatever your experience is for that latest period is going to flow through into the renewal. So you're just basically delaying the impact of that experience if we believe that experience is going to continue. Under a self-insured approach, an employer in this method, you're paying the bills as they come every week, every other week, once a month. And there are ways to be ready to pay, high months versus low months. And that certainly is how you set the plan up to make sure you've got a little bit of a margin and a cushion to pay some high months. But then there's also mechanisms on the outside called stop-loss insurance that protect you against catastrophic claims. So you want to be able to manage the cash flow from month to month, but then in the event of a catastrophic claim, that $2 million claim, and frankly, we are seeing $2 million claims out there, we would never advise employers the size, I think, of what we're talking about with the county and the school district to bear the risk of those claims, but instead peel that risk off to outside carriers, depending on what is an acceptable level. I've already gotten into the second item, and that's just cash flow. It's very predictable on an insured basis. It's heads times premium. That's what you pay every month. A little less predictability on a self-funded plan. You're going to have some high months. You're going to have some low months. And especially, for example, with school districts, we see a lot of seasonality in the claims. Summer tends to be hot when teachers are going to get care and schools shut down. And then we see some different seasonality around the holidays with employers in general. So you just got to be ready for that variation in the cash flow. Now, key feature here, when you sort of boil it down at the end of the year, you tend to pay less in a self-insured plan and you tend to pay more in an insured plan. Now, that can vary based on your claims in a given year, but when you look at this on average over time, self-insured plans tend to be a more efficient way to finance a program than an insured plan. And there are a number of reasons for that. One, insured plans have premium taxes that largely you don't pay in self-insured plans. With ACA, healthcare reform, there were additional taxes that were imposed to help fund high-risk pools that are in insured plans that are not in self-insured plans. And right there, that can be 5%, 6%, that the self-insured plan basically escapes paying some of those taxes. Also, when carriers set rates, they tend to use a little bit more conservative assumptions than what you may see from actuaries setting rates of self-insured plans. When you set rates for self-insured plans, you tend to look at what is the real trend out there in the marketplace. Carriers tend to be a little bit more conservative because they don't want to be caught off guard at the end of the year, so they may build a little bit more margin in there. So that when you boil it down, again, the self-insured plans tend to be a little bit more efficient over time. And then last but not least, this whole vendor leverage. Obviously, it's important to have a good relationship with vendors. Insured plans tend to be a little bit more captive to what the insurer is prescribing, whereas there tends to also be a little bit more flexibility with self-insured clients to basically kind of unbundle and repackage things to better meet their needs. So there's probably some other ways you could look at this decision, but these are just 4 main areas that we thought would be important to share with the task force today.
Great. And I think as we kind of roll forward, it's important to carry that last bullet. I mean, what we're going to be talking about is how we control claims. And a lot of times the phrase used, how can we keep our health insurance in check? How can we control the rising cost of health insurance? And it's really the claims. That's what drives everything regardless of funding mechanism. And one other point relative to self-funding with public entities, in terms of you may think, well, gosh, this entity, they're really large, but they're fully insured, and we're self-funded. I don't understand why would that be the case if self-funded cases are always, or typically, less expensive. And you do have 11208 responsibilities. In other words, you have to set up a reserve of 90 days of claims and have that in an account. So the larger the entity you are, let's say if you're moving from fully insured to self-funded, that's a big number. And so sometimes that becomes a roadblock, if you will, in terms of moving from a fully insured contract to a self-funded one. And it's also, as we've seen, even when you go back in time where there was a deficit, you not only had to bring your rates up to where you could cover claims, you also had to build up that reserve and file that with the state. So there's, that piece exists, but if you really wanted to kind of weigh the 11208 responsibility versus margin with a carrier and premium tax, you know, then that's kind of becomes your balancing act. But one of the things as we move forward, I think that I'd say one of your bigger things that you can do with the self-funding contract is you've got flexibility with plan design, things that you can carve out, things that you can do in terms of plan design that help you control costs. And we're just going to do a quick reality check in terms of what's happening from a macro level. When you consider, I mean, the claims that we run through at the district, whether it's, you know, 400,000 a month kind of clip, those are medical claims only. You've got $3.5 trillion spent each year on healthcare in the U.S. And when you think about 5 to 8% increase, oh, that's a single digit, that's not that bad. But again, we're looking at a 6% versus 5% gets approved. That any percentage increase is difficult and is particularly bad if it compounds year after year. But the keys to this slide are the cost and the quality, and the 34% is actually unnecessary. These are the things where you start digging into how are claims being paid, what cost and what quality is incorporated into the care that our employees are going out and receiving. And so that's a big piece of what we're going to talk about going forward. But obviously the reality that we face every single month with every single HITEF is that we're looking at, hey, what more can our employees withstand? Okay, they can only afford so much. Their deductibles are high. But the bottom part of that slide, when you look at this, is what is really going to impact affordability is that now you got your younger generation, which aren't really increasing claims now because that's your healthy population, you hope, you know, absent large claims or chronics, but they're less likely to have a primary care physician. And so that's only going to increase costs as you go over time. And then when you actually start to access primary care if you're using an ER, and we're seeing billboards every day, 0-minute wait, 2-minute wait, 3-minute wait, and then you're going to go to the ER as opposed to your primary care physician and pay 10 times the cost. So these are the things that drive costs, and that's what we need to focus on, and that's what we'll be talking about today.
And when we talk a little bit later about what we're deeming 6 pillars to effectively manage a healthcare program, one of what we're trying to do is take a step back from a macro standpoint and look at some of the data that's out there. So key piece of our pillars are how we work with carrier partners, how we design our plans to support what we want to do. But a big piece of where we think the future holds is really trying to work more with the members and the providers. And one of the themes I think we're trying to solve for when we get to this in a little bit is a lot of nationally recognized studies out there shockingly say 20 to 50% of what employers spend on healthcare could be deemed to be waste. And that falls in these 5 buckets that you see here. That price, basically procedures or services people may seek, there may be alternatives that are lower price and similar or better quality. And we're going to show you some data on that a little bit later. Care and coordination. So as the PCP coordinates with a specialist, there sometimes is redundancy of services and lack of communication between all the providers. That creates extra costs in the system. Fraud and abuse, we know that exists, and you know there's different areas that comes from, and largely a lot of the carriers are really trying to vet that out and really eliminate that from the system. Overtreatment, I mean, when we look at how care is delivered in the United States, you know, right or wrong, it's different than how it is in other countries, and you know, some could argue that maybe we do some procedures here for the general population that, you know, maybe are unnecessary, and that contributes to some of the cost. And then just administrative complexity. I mean, healthcare is complicated, and there's a lot of stakeholders, and there's a lot of pieces to the puzzle. How do we make this simpler for the member to get the care they need with a good outcome and maybe get some of the noise out, which has some of that cost? So again, as we look to work with clients and design these 6 pillars, we encourage us to kind of remind ourselves this is what's going on, and this is a big piece of what we're trying to solve for. Frankly, some of this, if not a lot of this, is out of our control in terms of, changing the provider community and how they deliver care. I mean, that's going to take years, if not decades, to change that paradigm. But as long as we can maybe figure out little ways to do it over time, and a lot of employers are focused on the same thing, it can change the system over time. So just diving a little deeper now, we're going to talk about pharmacy, and this has been one area that has received a lot of attention for a number of years now. And when we also talk about self-funding a plan, this is one area that employers who self-fund tend to have a little bit more flexibility to do things that are a little bit more different, a little bit more innovative and aggressive, maybe than if you were insured and having to rely on just what the carrier allows you to do. I'm not going to take you through all these, but as you look to manage care within pharmacy, there are a lot of tactics out there. Some a little bit more traditional, like trying to incentivize and encourage members to take generics versus brands. That clearly has a big impact on costs. Communication strategies, I mean, we want people to take their meds. And frankly, some of the data that I'm looking at for clients is showing that as people are adherent to their meds and taking some of these specialty meds, we're seeing reduced costs on the inpatient side, which net is actually leading to some better cost and some better outcomes. So I think that proposition we were trying to prove years ago with taking, the prescriptions is a good therapy, and that's a good investment of cost. We're actually now starting to play out and communicating that to members. Lucianne's going to talk in a moment about group purchasing. That we think is also a tactic to band together with other employers to create a bigger group to strike better deals with the pharmacy manager. That's something that we would encourage employers to do. What's more evolving is around tiering networks, maybe not having all the chains in the networks, trying to drive some better pricing to limit the full range of pharmacy that are available without compromising people's access to pharmacy. Two, actually some of these what we're calling more transformational. So let's build the pharmacy plan around value-based drugs. So should we charge a copay for diabetic medications? Maybe it's more important we create no barriers for diabetics to get their care, because in the end, net that's going to create a better outcome and lower cost. That's what we're trying to do around value-based. And then some of these new specialty meds and even genetic testing that's coming. So more to come on that, but a lot of options when we talk about managing costs in the pharmacy arena.
Prior to October 1, 2017, the prescription drug benefit was carved in with the Florida Blue medical benefit. We did a marketing in effective October 1, 2017.
Can you try to speak into the mic a little better?
The pharmacy benefit was moved to Express Scripts. And with that, we achieved savings, and you can see on this chart, of approximately $400,000. And so what the chart is showing, if the plan had stayed with Florida Blue, it would have been approximately $400,000 more. And this is primarily achieved through discounted rebates, guaranteed rebates that were negotiated. So as you can see here, and as Paul was saying, that carving out the prescription drug benefit was beneficial and saved a good deal of money.
So as we maybe change gears and look, okay, how do we move in the future? What do we feel is an effective way to look at a healthcare benefit program and develop some strategy and tactics to manage competitive benefits with managing the cost and the trend of the benefits? We've got this 6-pillar strategy. So it's built on a lot of what we've been doing over time with having the right vendor partners, financing the plans in the proper way that's appropriate for the organization, being efficient in how we deliver the benefits, being clear to members how to use benefits so they can get the right care at the right time. And then that's on the right-hand side. And then this other piece that wraps around is setting the right plan design so that services are priced fairly. There's an equitable cost share between different coverage groups, singles versus families, the employer versus the employees who are enrolled in the plan, people who are using care in the right way, primary care, we're setting the right cost share to just reward efficient, use of providers, the right care, maybe waiving copays for diabetic medications, trying to get people to get the right care at the right time, a lot of that plan design. But the pieces in the middle, I'd say we've been doing that over time, but we believe that's really the levers we got to start pulling harder and more in the future. And that is these areas of really coming back to primary care. And Jeff is going to talk about this in a moment. And a lot of the national initiatives to better outcomes within Medicare, for example, are really trying to get back to the primary care model. It's not easy, given the shortage of PCPs and some of the challenges with access to care, but we think that is important. They really are the hub of care. But there are also some alternatives, too, to do that care outside of just the PCP. But then we feel the next three pillars here are really engaging members more and deeper than what we've been able to do with communication and data and right plan design to encourage people to get the old adage, get the right care from the right provider at the right time. It's been, said a lot, overused a little bit, but it really kind of boils down to what we think is important. And then a big piece of this that's been a little bit of a hard nut to crack so far, but one we want to work on in the future, is just trying to get members to the right facility and the provider for the right care. And we're going to show you some data in a minute. Just because that provider does a lot of advertising or they're the most expensive doesn't mean they're the best out there in the market. And it's trying to get that data, bring it to the member, and get the member wanting to go to that appropriate provider at the right time. And then what I've given some examples on are just reward these high-value behaviors. People who are using the system the right way, let's encourage them. Preventive care is a good example. That's a good investment of dollars because that's going to lead to better outcomes over time. So these are sort of the framework for how we would encourage employers to then develop the right tactics in their plan design to support these behaviors.
So this slide is showing us regarding the inadequate primary care resources. As we can see, one emergency room visit equals the cost of 10 primary care visits. And which is showing that the reimbursement system is not value-based today. It rewards sick care versus preventive care. Millennials, are less likely to have a PCP. They will use a retail clinic. Urgent care was initially introduced to save money, to reduce emergency room visits. And we're seeing that it actually is an increase in cost, about $14 per member per month in cost. The system has evolved to one where comprehensive primary care is undervalued while acute episodic care is overvalued in the delivery system. So where do you think people invest? Well, if you can see, there's a growth in urgent care clinics of 20% between 2015 and 2018. And this slide is showing the primary care is a fundamental component of healthcare. And you have the PCP, which is traditional primary care physician. And then you move over to the patient-centered medical home, which is the best described as a model or philosophy of primary care that is patient-centered, comprehensive, team-based, coordinated, accessible, and focused on quality and safety. So it's bringing the patient all together with one patient-centered medical home. You have telemedicine and remote visits, which are 24/7 access, 365 days a year. And generally that is for more of an acute, I feel like I have a sinus infection. I'm going to call somebody and I'm going to get some medicine. urgent care and retail clinics, and they do address a little bit of preventive care, and they offer extended hours. And then employer-sponsored clinics and on-site services. And most provide acute care and coordination. CareHere, which is the district's on-site wellness, they provide wellness services. And as we note in the call-out box, of the 16,000, there were 16,671 PCP office visits at the CareHere Employee Wellness Center with an estimated savings of approximately $219,000, and that's an annual savings. And that is just primary care visits. It doesn't include prescription drugs or anything else.
Okay, so when we move to the next aspects of our strategies, I think we start to focus on how do we help employees, because at the end of the day, they're the ones that are driving the claims. So one of the first things when we talk about how we can engage employees and connect them to the strategy of the entity, a couple of, when you look at those hexagons, you had the selection and proficiency. A lot of it was education focused. So you had a lot of advocacy. We have benefit guides and communication in which we support the district, but it becomes an education effort, and employees would call an advocacy line and say, am I eligible? What plans do I have? Is this for me? What do I do? And so those are those top ones where they actually select the right plans. They're choosing things that are valuable to them. They know how to use them, and so there's an education focus. But when you get to the middle, where things are moving with respect to guiding and enabling employees, is helping them actually access care in the most efficient way. So when you're talking about improving their health, reducing risk factors, or getting them access to care and quality, that's really where we want to focus now. That's how navigation and advocacy has evolved. And really, if you look at an employee's health experience, and as they move around from a lot of the typical wellness things where we want them to be healthy, we want them to be educated, and they call an advocacy line. These people aren't really in the system yet. They haven't incurred a claim. They're not sick. They're not thinking about it. They're just being educated. But as they move around and they actually start to access the system, something's already occurred. So now we're trying to figure out where do they go, how are they cared for, and that's where we have some transparency, price transparency, cost and quality that's entered. And really, as they move around that continuum and they're actually needing care, they're really in the system. Those are your chronics, and really that's where a lot of your claims are. So managing, care management, your diabetics, your chronics, your specialty meds, these are the things where we really need to manage that care as well as just educate them on the front end. So that's a lot of what the clinical guidance is around the care management. And this is just a graphic as to some of the questions your employees might face when they think about the vendors that are out there and how we can help build a system that helps support an entity in helping an employee navigate the system. You see some of those questions like, what do I cover? Am I eligible? Have the right doctor? And advocacy, one of their biggest value propositions initially was helping an employee resolve a claim. Something was out of network. They were getting balance billed. They didn't understand the paperwork. Help me resolve this. But again, when we're managing costs and trying to figure out how we kind of curb this trajectory, that claim's occurred. So it's valuable to the employee, but we're not impacting the cost. The cost has already occurred. So really, now when we look at the right, where you talk about diagnosis and treatment options, that's where we actually want to leverage the data that we have, understand what the providers in your area look like from a cost and quality perspective, try and figure out, yeah, I mean, they're in network, but is that the right one? Or is this procedure actually required? These are the things that take some involvement, and yes, education, but you have to kind of build a system that can help your employee get there.
Let me share two slides that illustrate some of what we're talking about here from a data perspective. And when you look at this slide here, no, it's a little busy at first. Let me orient you. Let's look at the right-hand side first. And what that shows from this national survey from 2013 through 2017 is the growth in healthcare spend for the different types of services. Green being prescription drugs, red being inpatient care, and then you can see the other three lines in the middle. And this shows the growth in the spend for those services, but gets back to what we're starting to see in some of the data that, yes, we've been investing in prescription drugs and spending more on prescription drugs, but boy, look at, it's been slowing the rate of inpatient care, which is still pretty expensive. So we're seeing net that is a good value prop. So when we talk about how to set the right plan design, that's something to keep in mind. But what I also find is fascinating, which is going to get to the next slide, which is our whole theme of getting people to the right provider for the right care, is what's driving those costs. And when you boil it down, in simple terms, healthcare costs are utilization of services and unit cost, the price of the service. And there's more than just those two buckets, but those are the two big buckets. When you look at that data on the left-hand side, over these past several years, it's pretty clear, it's been unit cost that's driving the healthcare cost, not member utilization per se of services. Yes, the use of prescription drugs, for example, has been up over this 4 or 5 year period, and we said that's a good thing. But look at the cost. Now, granted, prescription drug costs are up as well, and we can talk about what's leading to that. But it is largely a cost issue we're trying to solve for versus maybe a utilization. Not to say we shouldn't continue to focus on utilization and make sure people are getting the right care and using services appropriately, but a big piece of this is how do we tackle the costs? And frankly, some of this we can solve for, but some of it you can't. The hospital charges what they charge per day, but let's get them to the right provider for the right care, and that's going to get at the next slide. So this is, I think, kind of a silver bullet, and it's hard data to get. We as a firm and some of our competitors are trying to build this data set. The carriers are trying to build this data set, but we think this holds a lot of opportunity for the future. And this is really trying to get at true cost and quality data for procedures at providers in the community. So we are working hard right now as a firm to build this data in as many markets as we can in the United States. Unfortunately, it only exists in a couple markets in Florida now, some of the more metropolitan areas where we can get the data. But our goal is to try to build this in other markets over time. And what this gets for, and this is a real chart. I forget what market it is, but it's a real chart. And this shows, and we're also focusing on procedures where people can plan for. So obviously, emergency heart surgery, that's a little hard to plan for. But MRIs, imaging, hip, back, knee surgery, where you have your condition, the member can be counseled, and we can present some facts and data to them to make a better decision. That's where we're trying to tackle it first. So this is an actual market in the United States that shows the various providers in that market, A through J, who deliver that care, and what the average costs are for that procedure, and what their quality outcomes from independent rating agencies are for the outcomes on average. Green is good, yellow's okay, red's not so good. The theme here is that more money doesn't necessarily buy better care. Now, there's 2 green at the high end, but there's also 3 green at the low to mid end. And that's the type of data that we want to share with employers to then engage employees and share with employees as they seek care. Not to say you can only go to the first 5 on the left and you can't go to the other ones on the right-hand side, but just through the right plan design, communication, and information, start really trying to empower people more to make decisions based on some facts and not just who's advertising on the bus or the billboard that day.
So we'd be remiss if we really didn't talk about keeping the employees healthy. And there's a huge focus with all of our clients, including the school district, in keeping employees healthy and focusing on wellness. Now, wellness is kind of the old term, so you'll see on this slide it's well-being, which is more, wellness kind of implies the physical aspects of things. Let's make sure our employees are eating healthy, they're have pedometers and they get their steps in and do things like that. When you consider well-being, it's different factors. It's the emotional, the physical, the social, as well as the financial. And there's also a lot of focus now on financial well-being with employees, stress associated with managing a budget, and understanding the financial impacts of things, and the social pieces of how you can navigate within an employer setting, and the stress related with that also impacts health. And really, kind of a common denominator with a lot of these is just stress and what that wear and tear is on the body. But you know, when we're trying to figure out how we try and control costs, this is an important piece of any strategy. The only drawback sometimes is that this is there's a longer tail on this. You have to build it and hope they come to a certain extent. And so what happens is, and what we've done with a lot of our clients, and Luciana included, is if you can incorporate plan design, metrics, data that support this strategy so that you can start to focus on BMI, some data around if obesity is a driver for either high blood pressure or pre-diabetics, that you start to manage some of that and give employees access to, but it is just it's something that has a bit of a longer tail on it. Now, with that comes this wonderfully confusing, and you guys can all chime in on this one, but you see wellness vendors that are there, but you also see navigation vendors. So if in the upper left, we talked about guiding members to the right care, and so you see live navigation and digital. So the difference being is, are they going through a system? Are they going through the computer to find care, and is that digital, or are they actually speaking to someone and they're telling me where to go? And then you have different vendors within each of those buckets. And as you move around, you're going to see maternity, PT, telemed, diabetes. There are vendors that can focus on very specific areas of your program. But again, as we do when we look at claims on a monthly basis with HITEF, if you're looking and you see a spike, where did it come from? What is it? What's happening with these different pieces? And is there something that we could potentially incorporate that might make sense? I think, you know, having CareHere, and you'll obviously hear from them and the Blues with respect to their support and what they can provide, you know, on-site. You give employees access to support. This is just a kind of a vendor depiction, if you will, of how many vendors there are that we can help navigate you to.
And I wanted to add something to what Jeff was speaking about in terms of employee support. Indian River does have an on-site Florida Blue representative. She's actually sitting right there, Marlena. And she's a resource for employees to go to with any sort of question on for their health care. And I think that's a really good resource to have. It helps with the navigation part of the system. So we're going to kind of wrap this up. So Aon's point of view, success requires focus by employers. And we have 5 bullets there of developing a data-driven strategic framework. Review your data. Know your people, build around their needs. And like I mentioned, Marlena is a good resource. She would get to know people because it's not where the benefit staff could talk to people about their obviously their illnesses or anything like that. You know, Marlene is doing that. But at a high level, if people are having difficulty in one area, she can relay that back. And it may not, you know, not a personal issue, but, you know, I don't know how to do this, or I'm going to the doctor and they're saying this. One other thing some employers must do is to clearly define what success is. And that probably should be like the first bullet. What is success? What is success in your organization? It's not the same as for every organization. A demand integration of data and measure results. So I know that monthly we meet with HITAF, we look at the data, and we see, where claims are going up, and Jeff mentioned this, what caused this? And
Can you explain HITAF? Because other
sorry.
individuals might not know what that is.
That's Indian River's Health Insurance Advisory Task Force. And we have, there were 3 members back there. There were 2 sitting back here. We meet monthly on the 4th Wednesday at 4 o'clock, the room right around the corner. And we review the health plan as a whole.
And who's in that committee?
I'm sorry.
And how's the committee made up?
Do you want to speak to that?
Our HITAF committee has members of our retiree group. We have CEA, which would be our teachers union. We have CWA, which would be our other union, and the benefits staff, and our CareHere staff, and Aon, our brokers. We're all involved in this monthly meeting to go over everything to do with benefits. Our health insurance, but also we speak on dental, vision, open enrollment, wellness plans, anything to do with the benefits department, we pretty much go over monthly.
Okay, thank you.
And the last bullet, stay the course but maintain flexibility. Not everything's going to work for everybody. You stay the course, but if something's not working, you can change it. So, thank you for your time. I guess we...
Okay, thank you. Great presentation there. A lot of information. At this time, we're going to hear from CareHere, and I'm going to pass out their PowerPoint.
Pass the baton.
And just a reminder on the schedule, from 1 to 2, CareHere will have the clinic, the Health and Wellness Center open for tours for individuals here that would like to take a trip over. And the address is right here on your schedule. You ready?
Good morning, everyone. Thank you so much for allowing us to be part of your workshop today. As we mentioned earlier, we are CareHere. We partner with the school district to provide on-site employer health care. My name is Lacey Marsh. I am the Senior Director of Operations. I have worked for CareHere for 10 years and have been in partnership with Indian River since about 6 months into their contract, and we opened the center in September of 2014. And I'll let the rest of the team introduce themselves.
My name is Patrick McIlharney. I'm the Business Development Lead for CareHere. I've worked in healthcare for about 25 years in various roles, to include pharma, management consulting, and even some IT companies, EMR-type companies as well.
And my name's Diana Bays. I am a registered nurse, and I'm the Director of Clinical Services. I've been with CareHere for 4 years and with the school district health center since I started with CareHere.
Okay, so CareHere, there's a human element to all of this. I mean, everybody's going through a lot of information, a lot of data. You guys put in a lot of effort. But at the end of the day, this is about your employees and their families. And if you can improve the health and well-being of people, then that's what it's all about. And that's really what we stand for. From our founders, our mission, we partner with employers to inspire their employees and families to achieve health and well-being through innovative, quality, cost-effective healthcare solutions delivered with enthusiasm and compassion. And when we go about our business, what we try to do is keep the patient in mind first and keep the client in mind. And when we do that, we typically get better clinical outcomes, and you get a better patient experience as well. So So CareHere is based out of Brentwood, Tennessee. We've been in business for over 15 years. We have over 200 health centers nationally, and soon to be 30 health centers in Florida. We've picked up a couple of new clients, a county-level client in North Florida and another city in South Orlando. 70% of our business is in the public sector. We're very comfortable there. We're good at it. 46 school districts around the country. So suffice to say, we're very familiar with some of the dynamics and the unique nuances that you guys experience. Typically, public sector, you have higher retention rates than the private sector. The age demographics are a little bit higher. So you have to approach things a little bit differently with that. We're an advanced patient-centered medical home. I think you heard that term from the Aon folks a few minutes ago. And I guess that little wheel there kind of is sort of the reciprocal of a slide Jeff put up with the vendors, the ecosystem. So we try to make it simple and build everything, keeping that patient in mind. So our technology, for instance, we have a mobile application. The idea is for the patients to easily be able to set appointments. They can do so in under a minute with the mobile app. So there's no phone calls or anything. We want to engage those patients as well so they can access wellness programs through that mobile application as well. Our health coaching, again, all run out of the health center. The services that we're providing are primary care and preventative care, acute care, disease management. You get your labs and medications on site. So the one-stop shop matters for people. A lot of people don't realize when you go for that lab visit, it's typically a separate appointment on a separate day. So that's time away from work that's avoided by using the health center. Okay, I'm going to turn it over to Diana.
CareHere does provide wellness services as part of our services, and with that, we often find that identifying someone's wellness goals also identifies their well-being, as we've mentioned earlier. We offer on-site wellness services, we offer telephonic, we offer classes, many different options. If patients are engaged in wellness and they're diabetic, they can get their diabetic supplies from us for no charge, which again increases compliance. Just many options for wellness that we have available. We have a app. Part of our app is patients can track their wellness and incentives through that also. One of the things, at our CareHere Center with Indian River County Schools, we are running a 91.4% utilization with our provider hours. That is very high. We've recently added 20 additional hours, making 120 medical provider hours available with MDs, nurse practitioners, and physician assistants. We do offer 17 lab hours throughout the day for fasting lab work, and some additional lab hours in the afternoon for non-fasting that aren't accounted for here. We are open from 7 a.m. to 7 p.m. Monday through Thursday, 7 a.m. to 5 p.m. on Friday, and actually we just changed to 8 a.m. to 1 p.m. on Saturdays. And with that, patients can schedule appointments for wellness appointments, sick appointments, chronic care appointments to meet their healthcare needs.
So in our partnership with the school district, one of the things we do is provide lots of different types of reporting. And this helps us to determine the hours that the health center is going to be open as well. So they asked us to cover how we choose the hours for the health center. So once we've determined the employee lives, we do a lot of tracking on when patients are visiting the health center so that we can determine the best hours to be open. So this is just an example of the reports that are provided where we look at to make sure that patients are able to get into the facility. And if we see things creeping up over that 85%, which this health center has, that would be the reason for the additional hours that have been recently added. And then on the next slide, you'll see just a dashboard of the difference between our activities so far in 2019 versus 2018 for our utilization. We've already had 12,700 appointments for this year. Utilization has remained around 93.5%, and we've had 1,563 unique visits for this year. So you can see, just based on last year's trend versus this year's trend, that we will certainly exceed through the rest of the year the utilization at unique patients and visits. Thank you.
Thank you. Did you have information that shows what we're actually saving by having the health clinic? Did you have that?
We don't. We were just asked to provide
Okay.
some determination on
Okay.
hours and the services
Well,
we
in
provide.
that first presentation that I had handed out, there was some of that information on there. It looks like on page 7, it looks like what, on page 7 at the bottom, CareHere average cost per appointment is $40, whereas the average cost per medical appointment is $85. So every time an employee comes to the clinic, it seems like we're saving at least $45 per appointment.
Yep.
And then in addition, we also, the school district, correct me if I'm wrong, but we also have there is no out-of-pocket fee for the employee to come over to the health clinic, and they also get their medication at no cost.
That's correct.
Is that correct? And we have a really good chart of what we've saved having the health clinic in the district, and I'll make sure that everyone gets that. I'll email that out to everyone. Let's see.
If I might clarify on that for us, Mrs. Zork,
Yes.
the advantage to us in that model of delivery is that the CareHere expenditures are not part of our claim cost. We heard our experts speak to the number one factor, influencing factor that we have to control cost is claims management. By excluding the cost of the CareHere appointments that we've just identified, those numbers are not factored into the premium projected cost going forward. So in essence, we all know in the insurance world, we're paying premiums based on experience. So those experiences are not factored into that dollar amount. By paying that cost directly, excluded from our policy per se, then we're kind of looking at two different factors of numbers, and that's probably the greatest impact on what we're seeing today.
Okay, thank you. At this time, I'm going to turn this over to our county administrator, Mr. Brown, and if I could have staff get your PowerPoint up, and then I will pass out a copy of your presentation. There you go.
All right, thank you, Madam Chair. Thank you for inviting us. I think this is a good thing for us to get together and discuss some of the things we're doing. I'm heartened to see that we're seeing some of the same things from your broker that we hear from ours. So, you know, at least there's comfort in knowing that we're not the only ones going through this. And sharing of ideas, I think, is a good thing. We can maybe learn from what the others are doing and not have to reinvent the wheel. So thank you for that. I think, some of the things like the medical costs, I know we've been looking at those knee replacements, the optional hip replacements and things like that. I think it's Surgery Plus or Centers for Excellence where you would set up the plan to drive the employees and the members to providers that are not only low cost, but have the best outcome, that have certain controls in place, like a one-time fee that if there needs to be follow-up, some of these things like this where there's one amount for the knee surgery, and if there's complications, that's not any additional funds, and reduction in co-pays and co-insurance for these types of things. So these are things that we're looking at as well. So heartened to see that. And so I'll just talk from the big picture largely and turn it over to Suzanne, who knows more what she's talking about, to talk about the specifics. But this is a major cost driver for us as well as most employers. Our total spend on health care is about $20 million a year. It's a significant amount. We hear of 6 to 8% medical trend overall. So if you look at on that $20 million base, we're looking at a $1.2 to $1.6 million increase year after year. So we, like you, are trying to see if we can bend that trend curve, because to the extent that you can't, those additional costs are just something that you're basically sharing. It's a determination of is the employer paying, which is the taxpayer, or is the employee paying? So it's kind of dividing up what those increases are. So to the extent we can avoid those increases, minimize those increases, those are things that we're trying to do with our plan design and the things that we're doing with our employees. But it's something that we always have to balance, that our limited resources and not burden the taxpayers any more than possible, but maintain a fair, competitive benefit for our employees to help with employee recruitment and retention, not to mention having well employees is good for your workforce, good for morale and productivity. Unhappy employees are not as productive. So those are the types of things that we are trying to do. In big picture, I saw the tipping point of affordability. As you mentioned before, we currently have just one plan at Indian River County. We are going to a high and a low plan. I'd say it's more like a high and a medium plan, a gold level plan, and what we're calling a silver level plan, but technically is still a gold plan as defined under the Affordable Care Act, but we're calling them gold and silver to differentiate those, and that's largely the reason we've made that change this year. Is those costs have gone up. You've got an affordability issue on the gold plan, which is what our employees have had. So what we're trying to do is provide a lower cost plan so that the employees can make choices with those higher employee premiums that are going to be faced with the gold plan. So providing some additional employee choice for us that enables our folks to make a decision, and looking at some additional advocacy. We've hired an additional health advocacy recently to help employees make that decision during open enrollment, which is upcoming in August, but also to help them through the challenging health environment beyond that, just helping with difficult claims, but helping folks navigate the overall health care services that they're utilizing. So with that, those are some of the high points of what we're doing, but I'll turn it over to Suzanne for the presentation.
Okay. As Jason said, we're entering into our open enrollment period for our medical plan, which is effective October 1st. And so this is timely that we're having this discussion. So we align our objectives for our medical plan. We want it to remain competitive, sustainable, and affordable. That's what's important to us as an employer. We have a very diverse group. It includes the Board of County Commissioners, the Sheriff's Office, the Tax Collector, Clerk of Court, Property Appraiser, and Supervisor of Elections. We have over 1,600 employees and retirees that are part of this group, and over 300 retirees on this plan. Total lives over 3,600. The average age of our subscribers, which include your retirees and employees, is 49.8 years. Dependents, 29.2, that includes spouses, And then the average age of all of our insureds is 38 and a half years. So what do we do to manage our plan? Well, we monitor plan performance quarterly. I do get reports monthly, but we get the full-on quarterly report that identifies areas of possible concern. We review our projected funding needs, make sure that we're on track. Finance, Jason, they allocate the necessary budget for OPEB and the employer contributions. We determine, does it look like we're going to have to make changes? We are going to balance our plan design with our funding requirements. We look for, how's the plan doing? Are we going to need to increase our funding? Where's that going to come from? What can we take on as an employer? What might the employee need to share in that responsibility of those increased costs? We work with our consultant to identify options. We have discussions throughout the year as we're moving forward. We talk a lot about trends and what you could be doing. And there's, as Aon knows, it's a lot of different options that are out there. And you really have to make sure that you're evaluating your options and you're staying aligned with your objectives for your plan. You talked about that it's kind of unique for each employer. So again, affordable, competitive, and sustainable is what our objectives are. So the strategies, we partner with our consultant who understands the needs of the group and offers options to manage increasing costs. We spend a lot of time identifying what is important to us, what is important to our employees. Disruption. You know, yes, we could do this, but what's the disruption going to be to the employees, to the retirees, and is it a good idea? We make sure that our contractual arrangements are appropriate. We prefer fee-based versus a percentage-based commission. Now, it's not to say there isn't some commission built in. We do have a broker on our life insurance benefits, and that is a commission-based product that's been in place for a number of years. We'll probably be looking at when we go out for bid, looking at that arrangement. While it's true that commission-based, you know, it's rolled into premiums, at the end of the day, for a self-funded plan, the plan pays it anyways. So the premiums go into the plan. So really, it's a shared expense, whether it's commission-based or fee-based. I just need to make sure that it makes sense. It's a dollar value that makes sense for the services that are being purchased. And that's whereas for us, for commission-based, it's just not as transparent. It's after the fact, and it's like, oh, okay, there's that number. So we prefer fee-based. We have ongoing conversations regarding trends, performance, mitigation strategies. We don't like surprises. We want to avoid the surprises. We want to develop a plan. We work with our consultant to identify options that fit within our objectives. We, again, maintaining alignment with affordable, that's the big one, competitive, and sustainable. You know, when you get down to affordable, some of us like to purchase a high level of coverage, and we're okay with paying a monthly amount to have that security. Other people, others of us, might say, you know what, I want to keep my money until I need to spend it for this item. So it's, and we have both. So that's really why we introduced that second plan, was to go along with that. The person who does not want to pay out of their paycheck every 2 weeks a higher level of premium for the higher level benefit, they'd rather maybe tuck it away into their medical spending account, and if they need to use it, then they'll use it for that reason. Another issue that's important to us is providing open and transparent communication regarding plan performance. Whenever we're looking at changes, we always go out and engage our employees and spend a lot of time having the discussions, and we're prepared to talk through the concerns and answer tough questions. So I think that's a really important part of administering a self-insured program. You have to be able to talk about it. You have to be able to answer the tough questions, you want to be transparent, and it's a hard message when you're needing to tell people that year after year, the expenses are likely going to go up. I don't know that we're really going to see a whole lot of down years unless we just have some amazingly good experience. So some of the steps that we've taken for our plan is we did carve out our pharmacy benefit to ensure that we get 100% of the rebate back and improve pricing, and that has saved us some money. Actually, for the first year, it was estimated about $800,000 just on the pricing and the rebates. A lot of it came back from the rebates because we'd get rebate checks, but we had no idea what's it for. It was like, we talked about, the check comes under the door. It's like, oh, okay, well, that's a nice amount. What is it for? And we couldn't really get that answer when it was a part of the Florida Blue program. So now we get the answer. Now we see the transparency, we know what that is, and we actually renegotiate our pricing every year with our pharmacy benefit administrator. They take our claims experience for the pharmacy benefit, run it through, and they tell us this is where your best pricing is, this is where your best deal is, and we're with Express Scripts as well. We also implement cost-saving clinical programs for RX. Now, you remember I talked about disruption, right? Disruption, change. You're telling me I can no longer get a 30-day count of medication for this prescription that I was used to getting it. Now it's down to 8 pills for the month. Quantity limits, step therapy, those are the kinds of things. But it's important because there was waste. And we don't like to have to realize it, to believe that. We don't want to believe there's waste, but there is waste. And if we don't make the design changes to address those concerns, then the plan is paying for unnecessary expenses. Now, disruption is low because there's no issues, there's nothing, no prior approvals, people just get what they need, but you're going to have increased costs. So the disruption is an unfortunate necessity in order to manage your ongoing costs. We offer the voluntary international pharmacy benefit. I don't know if you guys are familiar with that, but it was implemented back in 2016. It runs outside the health plan. It's not something that's recommended by our consultant. You're familiar, but it is something that we do. There is a cost savings when you look at the pricing through the pharmacy benefit, but there can also be a counter piece that we might not be getting some rebates through the pharmacy plan that when people are purchasing the medications through the international pharmacy benefit. So we recognize that, but at this point we continue to offer the international pharmacy benefit. We're introducing the more affordable, we call it the Premier Silver plan because it really has an actuarial value of just over 80%. It's like 80.5. So it's still a solid plan. And then our Gold plan is more of an actuarial value closer to 88%. So there's not a big difference in it, but it is a cost shifting where you have higher deductibles, higher out-of-pocket maxes, higher co-insurance. It's a 70-30 as opposed to an 80-20 on the Gold. Another thing that we did that you spoke to was the health advocacy benefit. And this is a new benefit that's taking effect August 1st. And this benefit is structured to not only help people with making their enrollment decision, but it's not through our benefit administration system, it's through our EAP program. So they actually are really good at providing this service to folks. It is confidential. It'll be 1-800 number that the employee can call either for EAP assistance or for the health advocacy. They'll have the ability to have a personalized health advocate assigned to them, and that health advocate can continue with them if they're pleased with that. There's a mobile app. They can report their concerns, claims issues. I got this letter, snap a picture, upload it to their health advocate. I need help. And our whole reason for doing that is a part of the disruption for change is that feeling that the employees are taking on, that it's just like, oh my gosh, it's another thing that I'm going to have to try to deal with, another decision, another, just that feeling. So this is someone who can partner alongside of them. You mentioned that the HR folks, we can't do that because we can't get into that, we can't cross over into that confidential medical. It's not a good place for us to be. So we need to really let the people who do this, the subject matter experts, the folks who are familiar with the various programs that are out there that I would never be aware of unless I had actually personally had to walk through it myself. So we're quite, as you can tell by the tone of my voice, we're quite excited about this benefit to see how it goes for the next plan year. And our hope is that it really gives a level of support to our employees as they navigate the difficult waters related to healthcare and making decisions. Another thing that we do, we have an annual health fair, and Florida Blue provides free on-site biometric assessments. It's part of our administrative services agreement. It's not an extra cost. And basically, we're wanting people to know their numbers. Step on the scale, you know, what's the waist, what's your BMI, what's your cholesterol, what's your blood sugar, and just get that feedback so that sometimes knowing that number will cause someone to go in a different direction. There's health coaching that's a part of that. It's one-on-one health coaching. And we're excited that we have that opportunity and that it's not an additional cost to our plan. We also do on-site mobile mammography quarterly. We have the mobile unit that comes. We were running it outside of the health plan, but now they got credentialed through Florida Blue and they're able to run it through as a claim, so they'll be able to capture the numbers a little bit more easily on the preventive care for the mammograms. We are also encouraging a relationship with a primary care physician and offering an incentive for the annual wellness visit. Go get that free annual well check. It doesn't cost you anything, and through the Florida Blue website, their wellness website, they can actually redeem the gift card under Cafe Well. So that's a part, it's an expense to the plan for the gift card, but we believe it's a good thing, $25 well spent to be able to do that. We also solicited proposals for our ASO service, our administrative services, for the plan to ensure competitive fees, provider discounts, and a broad network. Florida Blue came out as the best overall deal. You know, it's really interesting when you start looking at it, it's very complicated because it's like, oh, well, this fee is less, but this fee is more, but this is this. And then you have to look at it overall. What's your disruption to your network? Are your out-of-area retirees going to have good coverage in the state that they're living in? And our group, we have employees that live within a big region. They're not all in Indian River County. We recruit from different places, emergency services, our fire department. We have a lot of folks that travel in to work their 24-hour shift, and then they're off for 48. So we have to be mindful of that. If we were truly just a regional employer, we might have some different goals that were important to us, but it's a little bit different. And we do have that large retiree base that's out there. We rebid our stop-loss insurance every year. We're waiting for this year's. We won't get it until August. That's just the reality. They're going to wait and wait and wait and get that last bit of claims data, and then they're going to tell us what we're going to be looking at. This year, it's the early indications are that it's not going to be as favorable as we would hope, but we will continue to maintain that stop-loss insurance. We're going to evaluate the best stop-loss deductible for our risk, and then versus the premiums that we're going to have to pay for that level of coverage. So we're conservative. We don't like to roll the dice and risk the plan. We want to stay conservative and make sure that we have good coverage in place. Now, this is a really interesting thing that we did. We trained managers and supervisors on the importance of encouraging well-being and wellness in the workplace. We actually had a 2-day session of managers on the move. We brought in a speaker who does this. She's quite dynamic, and it really caused us as managers and supervisors to think about the culture that we have in our workplace. Now, I've been in public employment since the mid-'80s, right? And I have worked in places where it was really important that you looked really busy and you kind of hunched over and were doing your thing, right? And you think about that, that's the worst thing for us, right, to stay seated. And what are we seeing now? We're seeing workstations where people can stand and get up and move around. So we're actually challenging our managers and supervisors in their little micro culture for that work group. What can you do to encourage well-being and wellness in the workplace? Now, when I joined Indian River County, we made some pretty substantial changes in the HR department. I brought in a water cooler so that we could have water right there, right? We have a little employee, I call it the gym, but it's got the stretch bands over in the corner so you can, do some stretching. We have little weights and things like that. And we actually have little challenges that we put up on the wall related to squats, related to lunges, related to do this moving, to get this moving going. And we talk about it. As a manager for my work group, we talk about primary care. Remember to get your annual wellness check. Remember to, are you going to the health fair? Take advantage of that biometric testing. Know your numbers. We actually have a scale in the corner. Nobody gets on it. It's that old scale, that big metal thing that we used to have in the doctor's office that tells you how tall. But it's a reminder. It's almost like art. It's over there, and it's a little bit of a reminder that it's important that we just. Pardon me. Oh, yeah. So, anyways, we're really trying, because the reality is, if you build it, they don't come. You can build it. You can put a program in place. You can do all this stuff, but one HR department with an excellent consultant can't influence, right? That's not where the influence happens. The influence happens in that little group, that work group, that culture that's created by that manager for that team. And so that's kind of where we're investing some of our time and resources in doing that. The other thing we do, I have a person on my team who is very employee educational driven. So she is on it. I mean, our EAP, we have a part of that contract that we get free training. Well, when this person joined the team, it was prior to me coming, she's like, I don't think we're making all the use of these this training that's part of our contract. So she's on it. She gets the list, she plans it out. Every month we have a session, and it's about emotional well-being. It's about that wellness, those stressors. How do you deal with that coworker that, you might be having a little bit of conflict with? All those things that rob us of that energy, that positive energy that we want to keep to be our best every day. So we also focus on the financial. We're bringing in the FRS, hold those sessions, and we're partnering with financial institutions who will come in and talk about budgeting, talk about different things, loan repayments, just those kinds of things. So we're trying to make sure that everything that we're doing is aligning with where we say we want to go, and creating that culture. So we're kind of excited about that. And then obviously physical wellness. So what are we going to continue to do? We're going to continue to review cost-saving opportunities. We're going to evaluate programs to manage chronic conditions and identify best-in-class programs and providers. The diabetes management, that's an area for this next year that we're going to be looking at. We do have a diabetes program, but it isn't integrated, and there's some opportunity there. But I got to tell you, we're really, really cautious, because just because they do this thing doesn't mean you necessarily want to partner. So you have to be really careful and make sure that they align with your organization, that the culture that you're creating, that this extension of makes sense for your plan. So that's something that I'm looking forward to exploring that and getting something good in place there. We're going to continue employee education. So a part of that, I think it was 2 open enrollments ago, I went out and it was a specific targeted message of explaining the basic terminology to the employees. What's a deductible? What is coinsurance? And it's unfortunate that it has to be so complicated, but it is. It is so complicated. So I had One of the gentlemen out in our Public Works Department, he came up afterwards and he asked me if I was a teacher. I said, no. I did homeschool the kids, though, for a while. But I said, no, I'm not a teacher. And he said, well, you did a really great job teaching us about the plan. And I think that's important. So, bridging that gap of just because you're a smart person doesn't mean you're going to get it with it's like a different language. And it doesn't make sense the way that it works. So anyways, we're trying to support our employees with helping them through that as well. We want to, again, encourage care in appropriate settings, right? We increased our ER copay. It was $100. Under the gold plan, it's going up to $250, and under the silver plan, it's $500. Now, that's waived if it's a legitimate, you need to be you're admitted. So it's waived if you're admitted. But that was one of the ways that we had a good, we actually analyzed the frequency of visits. We never received the information of the individual, but that this particular subscriber, who remains nameless to us, has visited the ER 12 times in the last 12-month period, right? So, and it wasn't for those, a condition that you would expect somebody to go to the ER. So that told us, gee, that $100 isn't enough of a disincentive to keep from going there. So that's an increase that we made. And then we also made a change on our copay for our specialty imaging. We increased that as well. And it's co-insurance under the silver plan if you go to a setting attached to the hospital. And you know why? Because the cost of getting your MRI at the hospital to the plan is a lot more than going to a standalone facility. So, we're trying to do these things that help drive people to the right place by plan design. The other thing is we want to make sure that leadership is modeling and encouraging and supporting a me at my best lifestyle and self-care. There is nothing, we have the health plan. It's going to give us care when we need it for medical conditions. But there's a reality that lifestyle and self-care is so important to preventing these things that can become chronic conditions for us. So I think it's important to make that investment in the me at my best, being the best, doing those things, taking care of myself, not only while I'm at work, but while I'm at home, providing that level of support, encouraging the EAP, make the phone call. I was pleased to hear back from our consultant that we are really high utilizers under the Employee Assistance Program, right? That's a good thing. That's a good thing. So let's see. I think that's it. If anybody has any questions, I'd be happy to answer them.
We'll do that when we come back.
Oh, okay, great. Okay.
Did you want to wrap up? Is that good?
Yeah, I think so. So those are some of the things we've been doing. It's an ongoing effort, This is something that we're not going to ever be finished doing. We're going to continue to try and improve. I think some of the things that Suzanne talked about, like the managers on the move thing, I think we kind of had that mentality sometimes that, hey, the taxpayer's not getting their value if you're not hammering away at your job the whole time. But what it's clear is that taking those breaks, getting up, going for a short walk, doing 5 squats, standing up, can be helpful to someone's overall person and their overall productivity. So before it was kind of like a concern, well, we don't want anybody to see someone not working, right? Because that's the taxpayers' dollars being wasted. But at the end of the day, it's you end up with more productive employees if they're healthy, if their well-being is good. It's kind of like the adage, there's 2 people chopping wood in the forest, right? So they're there chopping. One's chopping wood all day. The other chops, and then he'll go away for 5 or 10 minutes, and he comes back. They get to the end of the day, the one that kept leaving and stopping their work had chopped more wood than the other. And he said, this is impossible. I was here working the whole way. You're going off into the woods, goofing off there. How'd you chop more than me? And the other person said, well, I was sharpening my axe. So when those employees take 5 minutes to go sharpen their axe, they're going to be better, more productive, they're going to be healthier, and when they're healthier, they're more productive. So we're kind of trying to work on that well-being that Aon talked about, to kind of, you know, because everybody's talked about wellness, we've tried wellness, everybody tries wellness. It's trying to make it effective. It's trying to make it work. You know, you've got to get it to where you're sending the right messages to your employees, that this is something that you can do, and to take care of your overall well-being, and that will end up helping on our health costs, but helping with a productive workforce as well. So I think that's covers kind of what we're doing, and thank you again for the opportunity, and look forward to the discussion going forward.
No, absolutely. A lot of good information here. We are about 10 minutes ahead of schedule, so what I would like to do before we jump into I have about an hour and a half scheduled for us to have questions and answers with the experts that are in the room, for the individuals, our county commissioners, our city manager, the sheriff's office, HR, and then our board here that might have questions for the experts while we're all together. So what we're going to do is we're going to take a 15-minute break, and let's come back at 10:55, and we'll jump into that, okay? So we're going to call this meeting back to order. It is 10:57. At this time, I have scheduled from a discussion session up until 12:30, and then the workshop will conclude after that. And then again, if in mind, there will be from 1 to 2. CareHere will have the center open for any individuals that would like take a tour of the facility. I think that's good, especially with our board members that have not seen it yet, and then anyone else that's interested in possibly having a health clinic themselves. At this time, how we're going to do this is I am going to have questions. Individuals, if you have questions for Aon, we're going to ask our questions to Aon first, and then we'll ask our questions to CareHere, and then we'll also ask in that order our questions with the county. So I would like to open the floor up for questions or comments, and I'm going to start down here with the commissioners. If you'll grab your mic, if you have any questions for Aon or comments.
Thank you, Madam Chair. Yes, well, again, gentlemen, you made some comment about ensuring that the employee gets the proper care. That's of paramount concern. And in doing so, we're running into many challenges, and that it goes beyond the presence in this room or any organization or branch of government other than the federal government when it comes to the high cost of pharmaceuticals. And when you're compelled to, when we hear what was being done with our plan as far as limiting those ER visits, because that was a phenomenon that was just off the charts, where people are now compelled to go back to their primary care physician. During a recent meeting, I compelled my thoughts about the prescriptions that are being written are totally off the charts as well now. So with the same thought process, wanting to have individuals obtain the medications that the doctors have prescribed is equally as important as getting the care that they need. Some of the employees have said that they have to go to a yoga class before they go to the pharmacy because of the stress and challenges and the options that they're going through to, well, if you could do this, you could do the mail order, we'll get back to you, and I did express it during our meeting, where there's a 72-hour turnaround. Wait a minute, the doctor just gave me my medication or gave me a direction for medication. But now I have second and third party involved with interceding with the application of my medications. Has anybody looked at the limitation of medications or the scope of medications? Again, that's not contradictory of what I'm saying, of covered prescriptions and then non-covered. Because quite frankly, I've heard people getting prescribed medications that are $1,000 per little tube, $1,000. If that's the case, if you choose to have that, that's not under the plan. And that would also give the opportunity for the masses to be able to get prescriptions at a fairer market price and less of a deductible without a third-party nod and approval after 72 hours of having to fight for your medication.
Sure. So thanks for the question. And
If it was.
Pharmacy is a complicated subject unto itself for a lot of reasons that you highlight. But to answer your question directly, there are some clients of ours and some of the folks on our pharmacy team who are looking at certain medications specifically and deeming them to be maybe not worth covering because they may be a repackaging of medications that may already exist or separate medications. So, when I sit in these meetings with some of my pharmacy team colleagues, they talk about certain providers who have taken like 2 meds that are out there that have been used, to treat pain, for example, and kind of put the 2 together. And instead of, $5 for this and $5 for that, it's now $1,000 when they put it together. Not to say it's prevalent, but there are some medications out there, like you described, that really don't have the therapeutic value for the cost of that med. And we do have some clients who are working with their PBM to specifically identify those and exclude those. So I think that's kind of one class. As you move away from that, there are others that are some of the new meds that are coming to market, some of these specialty meds, and some of our clients are saying, hey, let's hold off on covering them initially till maybe more evidence plays out and see that there is going to be value to this before we do cover them. So that's another tack they're taking. And then a lot of our clients are also looking at, the appropriate cost share. So I think it's been easy to argue the value of a generic versus a brand, and let's differentiate how we cost share on a generic versus a brand. I think where we're struggling a little bit as a community or an industry is how do we price some of the specialty meds. They're very expensive. They really improve people's lives. And I'm seeing evidence of keeping them out of the hospital, and net it may be a lower cost. How do you share those costs? Because they are expensive, and we don't certainly want to deny the care. So that one, I think, is a less, is a harder question to answer for a lot of our clients. So apart from how you cover and share the costs, I think it's also, this next layer down. Do you have the right deal? Do you appropriately bid the deal to maximize your rebates and your discounts? Do you maybe look at how you reconfigure the pharmacy network? Maybe you don't have all the major chains in, you pare that look back a little bit, and maybe it's not too disruptive because, there's a Walgreens across the street from a CVS. I mean, in a lot of markets, a lot of areas, and can we get better pricing? And, what we would say is there's a lot of pieces to the pharmacy plan, as all the plans that we're talking about, and just trying to, manage the disruption versus, hey, getting a point here, getting a point there, but still being fair in what we deliver. It's just kind of the different balls we're trying to juggle and, get the right balance for the client specific. But again, to your question, it really does, require looking at some of these different classes of meds and just what's affordable and what's right and what's fair.
Thank you. Well, while we're here, I don't know if you can answer this. I just have an unrelated question, although it's prescription related. This card that I see displayed in many doctor's office and pharmacy areas that says Good RX. Who pays for that, and how is it more cost-effective to use that than a plan that we're paying for. I don't understand. Sometimes not. Sometimes it doesn't apply. But who pays for that? And nobody has answered that question. And I figured, let me take advantage of your presence today.
I'm gonna have to call my pharmacy
Can't,
team
like,
to get
call
an
you
answer
to
to that
toss
one.
that
Yeah.
Nobody seems to know who
Yeah.
pays for this.
I was just going to toss that out as an employee-friendly way to defray costs. I mean, because it's one of the disruptors when you look at all the logos on the page. That said, what happens behind the curtain, you know, I know that when we do it relative to, you know, whether it's ESI or Optum or CVS, and looking at PBMs and what their formulas are and doing a typical evaluation of cost, which, as you described, this is what we do for clients. I can't apply that logic to that card. The magic of it, I think, is a lot of fun, but I don't know the mechanics behind the scenes.
And nobody knows, and you call the number and they just refer to the pharmacy. I figured I was going to take advantage of your some 50-plus years of
I will say this,
insurance
I
involvement.
don't think it's not addressing, and that's why you say it works sometimes and it doesn't on others. And I've seen examples where if you go brand on brand, you know, it's not saving you anything. And I would guess that the same thing is true specialty. But when you're talking about just re-engineering an employee's mindset of how they access care, it is one disruptor way of having them look for some level of transparency in where can I go. And some of that's just on a basic level. Where's their margin in a given generic even? But if you were to blow it up and say, really, how are they doing it behind the scenes? I wish I had the answer.
Nobody knows.
Yeah.
It's on my bucket list. I tried.
Yeah.
Thank you.
We'll try to get you that answer. Go ahead.
Thank you.
Sure.
I didn't put my questions in order of speaker, they're just kind of random as I wrote them down, but, and also I didn't have any preview of any of the information that's here today, so I do have a few questions and a couple of statements. I saw the note where the urgent care business is kind of growing at a double-digit clip at a pretty fast pace. I think hospitals have figured out putting these remote clinics out are just great cash cows because they use the brand name of the hospital to drive business there, but at a much higher cost. And here locally, we have Lawnwood is now branching into the county by building their first, in our area, Lawnwood Medical Center emergency room outpatient services in the South County area. So the competition is just going to keep, keep going. Obviously, the hospital here has bought a number of private institutions and build them now into the hospital, but they still have the old Vero Radiology, which had a great, community feel and was separately owned, but now that's a hospital-derived division. So we have to find ways to point people to those non-hospital-based ones because they have a much higher billing rate. And I don't know what the best way to do that, but your app seems to have some features, at least that give some indication of kind of who's who in the marketplace. So a couple of questions I've got, just trying to do some basic math on one item. When I look at the fiscal page, which is page 9, and looking at the clinic fees, I'm trying to figure out what is the real driver in the difference in cost between the county and the school board. If you take the total number of current enrollees and retirees between the school and the county, and then you look at total dollars expense, we're at about 20 million, Jason, roughly, and they're at 17-ish million, setting aside how we're paying for that portion of it. But if you just look at the cost to deliver the care to our two pools, there seems to be a price spread between you're serving more people at lesser dollars. Is that being derived from the clinic market, or is the clinic responsible for 25% of that savings, and do you have a different pharmacy plan than what we have? We know we've received some significant benefits in the change in our pharmacy plans that we've done, limiting visits to things like specialty providers like acupuncture. That kind of snuck up on us. But if I take the total number of people served, that's 16,671, and you take the annual clinic fees on that page of $1,970,000, that comes out to $112 per visit versus the $40 per visit listed as the average one on another page. And so you have 112 and you have 40, so which is the real number? I'm just taking the total clinic cost divided by the number of visits, comes out to $112. And then on the other page, it had $40 versus a Blue Cross number. It was a higher number comparison.
Who wants to answer that question, team?
I can take that. Great question. So there are several different ways that these costs have been divided, and the initial cost that was provided, I believe, by Aon was due to just looking at a per medical visit slot, which they came up with $40, so that when they were looking at a no-show charge, we could say, if this slot goes unused, it's going to be $40. When we run an annual report where we come up with a cost per visit is also including the labs and supplies that are utilized per visit. So your cost is slightly higher there than if you're just comparing an actual medical slot versus an actual medical visit. Because at the health center, unlike in the going to your regular primary care, you can have labs and medications dispensed to you right at that visit. So that's why you see a little bit of a difference.
So you'd have to
there.
kind of segment that number into how much of it was for primary care visit, how much of it was for labs and other items. Okay, so
Correct.
that makes sense.
And then the program management fee is also included in that
Right,
cost.
okay.
Yep.
If
I'd have-
I can help to clarify that, you know, if we go to see our doctor, we go for an office visit, and we think of it as one service. But when you see your EOB from your health carrier, it's broken down into 5 or 6 different charges, and you think, gosh, I didn't do all of that. That's exactly the model that she's referring to.
Okay, so you have to really kind of drill down a little further in breaking the numbers
And the
out.
way to do that, Mr. Zork, is literally we compare it by procedure code.
Okay,
So if an office
billing
visit is
code.
a 90821, for example, we know that we're looking at apples and apples versus apples and oranges.
Also, how did you guys, or how did the school district capitalize all the upfront costs? Because somewhere that had to be, it's not in the annual cost of the $1.9 million, so somewhere there was, or does the provider pay that fee as, look, you provide us a box, we come in and we bring all the equipment, the doctors, the phones, the lab equipment and all that, or is that capitalized in a different budget area?
We'll need to defer that to the person on our team that has the most history with that. We no longer have staff within the district that has that history, but fortunately, our consultants have been with the program since the inception.
And so what is initially set up is they utilize having a modular brought on site, so there's a cost to the modular that is assigned, and then any of the startup for supplies, computers, any of those kinds of things, those are included in the initial bill. So those were paid by the district in the beginning of the contract.
Okay, and then as they age out, then the district, under their CIE plan or whatever the district calls it, puts in, hey, we need to change this, and then it becomes a line item budget. And does that filter back into the cost into,
Yes.
or it does? Okay.
Yes.
I'd have to say, for many years going to the Florida Association of Counties conference, I think both of the vendors here usually have a presence there, and I usually just kind of scoot by that booth, and they're always trying to get you to come in and talk. But in looking at the numbers, there seems to be more merit. There's been a little more history of time being out there. There's a little bit more, seems to be proven results that are out there. I'm not necessarily saying I'm advocating to a clinic-type plan, but I can see where I was discounting it before, getting a little further down into the numbers is better. Not that you want to create another entity. But if we knew, like if you know, I think, Jason, you mentioned CareSpot is one of the more cost-effective, or maybe Suzanne, that if you go to the emergency room, that's your highest cost. So it's Sunday night, 7 o'clock, kid's got an earache, needs to go somewhere to get something. So you go, okay, care spot's open till 7, you start doing your little countdown and you figure out where can you get to in the window of time that you have. Do we know, so if you go to a care spot or you go to a Lawnwood or you go to the Indian River, one of their outside remote places, what a traditional visit costs us to where we know, because if I'm going to care spot thinking I'm doing a good thing on those nights and weekends time, but maybe I'm doing the opposite, not knowing.
Right, and the data is really hard to come by as far as what the cost is, and like you said, the procedure codes is really what tells you. And Florida Blue does not deliver procedure code pricing by provider.
Okay.
They don't give you that.
And the reason for that is because it's proprietary, because they're literally cutting that deal with that individual provider, and so
Right.
they don't want that provider to know you got a
Right.
$50 deal and you got a $25 deal. They protect that at all times and will not take any encroachment upon that business model.
So in the data that somebody had showed that was compiled from other areas, I guess if it's coming from another Florida market, you wouldn't want to take like Washington State or New Hampshire. You know, if it's coming from Florida, that makes it a little closer to home, and the reality is probably closer to that, not exactly, but probably closer. So you could make some assumptions that if you did this is kind of what you're looking at, that data that you guys did put together.
Yes, that is very market specific. So we're working as a firm with some outside partners that are frankly the clearinghouses of medical claim data for all the carriers. That's the source of that information. So it's agnostic to the carrier. It's kind of at the root of where the money goes, and that's how we're building up. And it's very market specific. So, for example, I believe we have it in Miami-Dade, we have it in Tampa, some major markets in Florida and outside of Florida as well. And for clients who have employees sitting in those markets, that's where we're trying to push that data out and use that data. So it wouldn't be applicable here, unfortunately.
Right, but at least it's still another Florida market. We're different than a Miami, but it's still Florida versus another state.
Absolutely, and we're hoping that as we and employers get on this bandwagon to say this is important, and we build it in some of these bigger markets, over the next X years, we can be taking that, to other markets across the country and certainly across Florida, as, we as a community are just trying to push out, this is important to all of us, and we really want to build this data, and we want to use this data. It's not a 1 or 2 year thing. It's going to take some time.
Right. Under the app, it had incentives. It was called incentives and something. What are the incentives that are, I think it was on the app. I know it was on one of the slides, but I don't remember which. It had,
Clinic, I think.
I remember seeing it on one of the slides. I didn't know what like at the county, they have that $25 gift card if you get an annual. Okay, under wellness services, does that have a page number? No, it's under CareHere. It has incentive programming and tracking. What are the incentives?
All of our client groups are different. Here, there's not an actual monetary incentive as in regards to a gift card or anything like that, but we do have groups that make plan design changes or add an incentive like a gift card or some type of reimbursement for completing an annual blood draw, as well as getting hooked up with one of the wellness coaches and working on maybe your blood sugar or your blood pressure, and then the report is provided that you went through that program and you get an incentive.
Okay.
Mr. Zork, I believe part of that incentive is the literal fact that our employees do not have a copay deductible. The employee advocate position that you all referred to earlier, we overcome all of that with the centralized care here, because the employee literally doesn't have to think about what's it going to cost me out of pocket. So their incentive to participate, and I believe the reason utilization rates are what they are is because they can walk in the door without cash out of their pocket and meet 80+% of their needs.
And
Right.
Including prescription.
Right, and Mary D has a great point, just as reference to another one of our reports just without any type of monetary incentive besides all of the great services they get at no cost. 946 employees decided to participate in an annual health assessment without any other incentive just than having the health center there, which speaks volumes to what they've done to promote the program.
I think it's important to note also that you all have what I personally think of as a traditional wellness program, which is what your HR department's implementing. Our school district does not have that program right now. That is a missing component that I think is going to have a great influence on our numbers. The empirical evidence will teach us that a wellness program, our ratio is a 6-to-1 ratio. We have had approval for a wellness position job description. We're just literally trying to find physical space, how that happens. Everyone in the room knows that we've had change in leadership, so we've had to kind of repunt that. It's on our top 5 goal that we'll be looking at very shortly, because I think that y'all are doing something very, very smart, very astute in making that responsibility of all of those things we've discussed by educating your employees. I think that that's, tremendous, particularly with the leadership involvement. I come from Monroe County. I spent 5 years in this same design that you all had, where we had 7 constitutional offices, including our good friends in law enforcement, which are, of course, the highest driven factor in those numbers. And prior to that, I spent 14 years in our school district. So I'm very familiar with those models, and the similarities are exactly the same, sir, between that county. And by the way, that FTE number was 1,600, which is the same numbers that we're looking at here today. And the wellness factor, gathering the biometrics is huge. It's huge. I could tell you a number of stories where we literally saved people's lives by being able to provide that service. Y'all are way ahead of the curve on that.
One more question back to the clinic providers. So in that $112 number, just ballpark, since it does include labs and prescriptions, so what would you just, a real guess of, out of the 112, what is the actual visit to the doctor or the physician's assistant side? I'm trying to get an idea of what that is relative, that if I go to my regular doctor for, I don't know, sinuses or something, and I'm paying a $25 copay, and then the county's going to pay, its plan's going to pay the difference. I don't know what that mystery number is compared to the 112 less the other things. Because then if I have a prescription, then I have to go, go to Walgreens or wherever and get it filled, and that has maybe a $5 or $10 copay to try to get the difference in how much more efficient and the cost is the delivery of care at the clinic versus me going to my regular doctor, paying the copay, the county paying its portion. Do you have any idea of what that is, Suzanne? I guess every doctor is sort of different, or are they all treated the same under the billing code if they're not related to a hospital?
If I may, I believe that we all have the data resources available where we could take 5 or 10 common diagnoses and be able to provide you with a comparison based on similar diagnoses, using your example of a sinus infection.
Right.
That would be pretty easy for us to do. If we took our top 10 indicators, I think that we could provide that, for you working with staff. I don't want to step.
Right.
I certainly don't want to create more work for myself.
Right.
However, I do think that we could collaborate on that and be helpful.
And come up
that way.
with, there's probably the top 10 things people go to the doctor for. Then you have all the specialty things.
Right.
But,
Okay.
okay.
So we
Thank you.
are-
I'm not hogging the questions here, but I did pay attention and I did write down a number of them. Yes, Susan?
I can tell you that for our plan year ending September 30th, urgent care, the spend per service, now this is not based down to the code, but the spend per service was $99 for 1,721 services. So the total spend was $170,000 for our plan for 1,721 services with an average spend per service of $99. But that does not include a pharmacy component.
Right, or a copay, which would be at least 25.
That is just what the plan.
Right,
Yeah.
the plan side cost, so, okay. All right, thank you.
So,
Oh, here you go.
thank you.
So I was told that the St. Lucie County Sheriff's Office contracts with a current existing urgent care, that they encourage their employees to go to a specific urgent care. Is that something that can be done, like, as opposed to having an on-site, to have a contract with existing urgent care where we would gear our employees to go to a specific one? And I don't know if it would be possible to have that like the on-site where those claims are not lumped in with our plan claims. I don't know if that's something that.
Yeah, and one of the challenges is running your payments outside of your health plan, and who's gonna be paying that bill? You know, so who's gonna be reviewing those visits to the doctor and the expenses? And you're getting into some PHI that, as an employer, I don't want people on my team having access to that PHI, so then you're having to pay somebody to do that for you, to pay that bill outside of your administrative services agreement with Florida Blue. So it really, does it end up being a value at the end of the day? I don't know.
Okay.
Can I?
Yes,
I
go
would just like to comment. A year and a half ago, St. Lucie County Sheriff's Office ended that contract with an urgent care, and they are now one of our clients. They partnered with St. Lucie County.
Okay, good. That's good to know. Okay. That was just something the union had brought up, that they thought St. Lucie had an urgent care, existing urgent care they contracted with. The other question is, you have the committee that meets monthly. Does the county have a committee, or who reviews the monthly reports, the quarterly reports that we get?
So, no, there's not a committee, and it's Jason, Kristen in budget, and myself, and sometimes Ann Rankin sit down to review with Lockton, and just look at trends, look at where it's heading, and then when it comes down to if it's looking like we need to make changes, you know, we review the information with a consultant for fit, disruption, and then once there's a preliminary, this is where it looks like we need to head, then we go through the information sharing and the discussions, the difficult discussions.
Okay, I was just curious because I knew when the acupuncture, I think maybe we only had maybe one or two sets of eyes looking at those reports, so I just.
So what was interesting about that is, and this was an issue with Florida Blue, Florida Blue's, that provider was very good at keeping it below the radar. And what got us on that was the number of claims, low-cost claims, under like a couple $100, boom, 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 boom. And it wasn't until we saw a disruption report related to changing our network with Florida Blue, moving from Blue Choice to Blue Options, that we actually got a specialized, which providers are no longer going to be on the new network, right? And that was the report we got. And that number was the over $1 million going to an acupuncturist, and Jason's like, that's even more than the hospital. What's going on here? And that began the discussion into drilling down and finding out frequency of visits. You mean we had this number, these 200 people who had 36,000 distinct visits within a 12-month period? Something's wrong.
And so this is something, so I got to comment on this a
Sure.
little bit more, where, you know, you've got HIPAA, so as the employer, we can't be looking at individual claims and things like that, so we're dependent on our ASO, which have to say I was quite disappointed in Florida Blue, because their answer was, well, a lot of health plans don't provide an acupuncture benefit, so they just didn't show up on the reports. So we would get our normal top 25 providers, we look at that, it was just missing.
Yeah.
So when we saw it was when an HR staff member discovered it, you know, much to my dismay. We pay a lot of fees to various professionals that didn't discover this, and not only was it not discovered, but the reporting that we thought included everything from Florida Blue excluded
Put it in an
acupuncture.
other category.
So when people wonder, oh, how did this happen? Well, how it happened was the information we were getting, it wasn't there. And as soon as we got a piece of information when we were looking at this disruption, somebody in HR said, well, that number doesn't look right. So, and so, one of the lessons we've taken from that is we have, and Suzanne's done a great job at this, is focusing on transparency. It goes from the fee versus commission question to all types of things. We're looking for transparency, peeling back the layers of the onion and seeing what's there. Now, there are limitations because of HIPAA, and you can't see PHI and all those types of things that are limiting, and there's a reason for that, and I fully understand that. But so that is something that it was just a disappointment that information just was never provided to us during that time period.
Yeah, and the other thing Florida Blue said is, they said, well, your plan let it happen. Which I was kind of like, and what they meant by that is, we didn't have a cap. So the board said cap's going to be $1,500 a year, and I think 26 visits, or there's a visit cap and a price tag cap on it. Well, what was interesting is the other acupuncturists that were on the plan and not committing fraud, were their costs to the plan were, under $10,000. I mean, what you would expect, right? So, it's one of those things that you don't expect someone to do that to you, but, now we're having to look at it like, okay, now we have to take the approach that everybody's going to try to rip us off, and we better structure the plan so that it's going to be hard for them to do so. How unfortunate is that, right? What do you call them, the bad actors, Jason? There's bad actors out there.
So, Colleen, did you have a question?
I have one other thing.
Oh,
can I
okay,
say?
go ahead.
Blue Cross rep on-site, the school district, you're on-site, like, every day, normal working hours? Have we thought about something like that, or is there
We
not
have
a
not.
need, or?
I don't know that there's a need. We have the Florida Blue rep on site monthly. We invite them monthly, and I don't know that it's a full.
Okay.
Somebody might not have their day full if
Jeff,
we were to
do
do
you
that.
want to speak to how we ended up having a rep? That was something we negotiated in our, so go ahead.
When we did the RFP back in early part of 2017, and Florida Blue was awarded the business, and one of the things that we negotiated into the contract was an on-site rep for the district.
We've just started gathering that data to look at the effectiveness of that program, and we'll be glad to share that with you in the future.
Well, I can say as a board member, when I first come on board, one of the largest complaints I had was I was getting panic calls from employees who couldn't get answers on their insurance when they're in the doctor's office. And over the last year, I've not had those calls, so I'm going to tell you it's working.
Oh, great, thank you for that feedback.
I have one question to piggyback off of your question. Could the county go to and put out an RFP and say, we want a proposal from a Instamed type clinic of whoever's, and because of the price of delivery from that provider is low enough that it could be a non-copay agreement. So instead of having a clinic, you just negotiate a no copay agreement with a clinic provider because their billing, their cost structure is lower enough that would allow that if everybody went to that you wouldn't have to have a copay.
You probably could, but then somebody would have to pay the bills.
Well, why? Well, if you go to the clinic now and you pay the $25, Blue Cross pays them.
Right, Blue Cross is the one paying the bills on
So
behalf
they
of
would
the
still
plan.
pay the bill.
They wouldn't.
They wouldn't.
No, because it's going to be through their relationship with the provider and their
Right.
negotiated rates. They won't give us a narrow network and to the fees that we might negotiate and administer that relationship with that provider.
Well, if Blue Cross won't, will somebody else do that?
I'm sure somebody would.
Okay.
Mr. Zork, how we handled that in the school district was they literally created a benefits accountant position to serve as an internal quality control that processes literally just those claims and those costs and provides us with all of the numbers and things that we need. and processes the literal invoices that she's speaking
Right,
of.
okay.
They found it to be extremely cost-effective because the primary responsibility for that position is reconciliating the vendor's invoices to our vendor's enrollment. And oftentimes, again, it's a fluid process. It's always, changing literally from the beginning of the day to the end of the day. But they recovered a lot of missed revenue opportunities. Good verbiage, huh? Just by creating that position and having someone responsible solely for that. It's been very effective for the school district.
Okay.
Thank you.
So we're going to move on to Mr. Carlisle. Did you have questions? Comments?
I've had a couple different companies come to me and talk about the directed healthcare benefits. I'm excited about that if the data ever becomes available. Jason and you all talked about, and you talked about the highest price isn't always the best outcome. And I've seen a lot of data on that, and I agree that could be a benefit. And, the city's so small, we're not big enough to have a clinic. I can tell you, Commissioner, I did a clinic in one place I was at, and I was working on a clinic in Glades County and partnering up with the Sheriff's Department. And I can tell you the benefits far outweigh the expense. I can tell you that the lost time of work, the coverage that the employees get, the feeling the employee gets when their child can go right to the doctor is far outweighs the mental aspect. So the healthy, happy employee is always better. My question to you is, and to say that is, when we talk about you using the international pharmacy, what do you think the effect is going to have with the new law that was just passed? I know the federal government has to approve the Canadian pharmacy, and we know Big Pharma is going to fight it, but how do you see that affecting the future of prescription drugs in our plans?
We each have, I'll give you the first take at it.
I don't think a lot's going to happen in the next several years. Just given the political climate, the differences of opinions on healthcare in the United States, the influence of different stakeholders in that part of the healthcare delivery, I think it's going to be slow. I think it is probably a post-2020 event. And that's why our advice would be, and our advice in general is, yeah, we have to comply with what the government is doing in terms of reform and regulation, but we can't let that distract us from kind of like our day-to-day annual plan management. We just got to keep chugging along as an employer because, that's just too unpredictable, I think, for a lot of us. But go ahead, Jeff, if you have anything different.
Do you have
Okay.
any questions for Aon or CareHere?
Well, I just continue to struggle with the reality that Medicare reimbursement, right? You have a Medicare reimbursement for services. And the disparity between that number and what a private health plan or a public health plan has to pay for the same service. And the lack of transparency related to the insurance carriers' arrangements for their fees and reimbursements with those providers. And that's just a real struggle for me because I've spoken with people in my own family. They've gone and had a procedure done, and they were smart enough to say, what's going to be your cost for this? $90,000. What's going to be your cost for this? $18,000. Where will I go? I think I'll go over here to the $18,000 one. And it's such a shame that there can't be a reasonable number that is agreed upon and maybe regionally adjusted for cost differences in various regions. It's just, and we wouldn't have to be in this boat of trying to come up with these creative ways to circumvent and make our own little deals. It's just frustrating. It's just a comment.
Agreed. I will say, just when we talked a little bit about digital and live navigation, it is one of the things with the live navigation, you have the quantums and accolades of the world that are really coming in and taking everything outside the network and managing that, which is trying to streamline exactly what you're talking about. It doesn't fix it. It's not kind of pulling back the curtain and letting us understand exactly what's happening and why there's such a disparity between, say, Medicare reimbursement and what the providers are charging. But it does have an operational avenue that you can access to streamline that and get to the lowest and most cost-effective care. So it's a stopgap, but that's what's happening.
And if I can just add, again, our encouragement is for employers to keep beating the drum, and then trying to take that, that theme and message to employees so that they can have those conversations in the family, with their doctor, with their providers, to just try to get the best care for an affordable price for everybody. And again, it's going to be a multi-year, if not a decade-long journey that we all go on, but it's just important to kind of raise that as one of the top 5 things really to focus on as we talk about managing a healthcare plan and a benefit plan.
Jason, do you have questions for CareHere or Aon?
Sure. I was going to have one question, but I'm going to do a comment in addition to Suzanne's. Is, it strikes me as a lot of these problems, they're allowed to do things in the healthcare industry that would be illegal in others, as far as collusion on pricing and things like that, that you couldn't sell cars or homes or cheeseburgers this way, but you can sell medical services this way, which is something that needs to be changed. And obviously that's a post-2020, probably post-20, many years into the future if anything happens. So that's a comment on that. And so we're stuck trying to work around this system that we have that drives prices higher. And then, so the question is the standalone ER. We haven't had one of those here yet. So we've got one that's being constructed in the south end of the county. We made a change to our hospital deductible in part because of concerns about what we've heard elsewhere happening, where people seem to treat that as an urgent care facility. And despite the fact that we hear, like our hospitals that would try and drive people to clinics to drive that cost down, it seems like there's a business model at play here where they're wanting to attract non-ER visits to a standalone ER, which you look at the size of it and wonder whether you think that's a real hospital, and whether you're going to get those care. My concern also is, my understanding based on the average pricing compared to Medicare is that's Lawnwood, which is significantly higher pricing for the services overall than either of our 2 hospitals in Indian River County, whether it's Cleveland Clinic or the Sebastian, the Stewart Hospital in Sebastian. So we've got a concern, and one of the things that we're trying to do is educate our employees that if you've got a fever, that's not the place to go, because it's going to cost a huge amount there, more than if you went to the ER in one of our other hospitals that I would characterize as a real hospital. So have experience that you've had in other places, does that seem to drive costs up when one of these standalone ERs comes to town? What's the order of magnitude? That's one of the things that I'm concerned about.
Yes, it does drive costs up, and it does have the pricing structure largely, it maybe not wholly, but largely of the embedded ER. So you're right. When we get to that PCP slide, it really starts, PCP, urgent care, telemedicine, really trying to get people to the right care at the right time, the right cost structure. And if there is a need for ER, obviously people have to go to the ER, and, that's just kind of what they need to do. But trying to steer the steerable visits to urgent care or telemedicine is what we're advising clients to do, and how we're building the benefit plan. But yes, that we're seeing in the metro markets in Florida, that standalone ER is there and has been prevalent for a while now, and does drive up the cost. So getting ahead of the curve on some of this is good.
And I think part of that.
They're going to a walk-in.
Right.
They don't even realize.
Right, and if you really needed to go to the ER, you're probably going to end up getting transported to Lawnwood in Fort Pierce.
So ending up in a more expensive facility than the local hospital.
Additional expense being transported.
Yeah.
And again, part of that solution, I think, goes back to the participant education. One of the things I've seen done in the past is in our monthly employee newsletters is to literally show them a comparison. If you need an MRI, this is your out-of-pocket cost at this facility, this is your out-of-pocket cost at this facility, this is your out-of-pocket cost at that facility, and they can see the variances for themselves, and that starts laying the seed work, if you will, so that they start thinking about comparing costs for other services that aren't of an urgent nature. Also, I keep wanting to say Blue Cross Blue Shield, I'm so sorry, that shows my age. Florida Blue also has a 24/7 nursing service in our plan. And we're trying very hard to educate our employees to use that because they can call a medical expert and ask for their opinion. The child's fever is 104, it's Sunday night, the baby's 8 months old. Is this an emergency? Do I need to go to the emergency room? And oftentimes they can help triage that decision-making. And as a young mom, I can remember doing that and just being so grateful that there was an expert who could talk me through that process and help me as a consumer to make that decision as well. So this year, in the last 6 months or so, you know how quickly time goes, we've really tried to encourage our participants to use that service. It's available at no cost to them. It's available at 2 o'clock in the morning. You know, 24/7 nursing services, you can't beat that.
I would also say another education piece I think we have to keep in mind is that some of these visits for the employee, they're paying the same copay whether they go here, here, or here.
Right.
They don't understand that it's costing their plan overall more going here versus here, and that in turn eventually has a big significant part of your annual rate increases. So that's a whole nother piece of education that I think sometimes we're lacking in, the difference between self-funded and fully funded.
And if I'm sorry, if I could just add real quick, we are having some clients, now you have to weigh, you got the right data you're looking at, and you balance that with member disruption, who are tiering some of these benefits. So they may be tiering ER providers at different copays within their plan. So you pick those ones where you have the data and you can do it, and it's the right thing to do, tiering some of those benefits.
Okay, thank you. We're going to move on to Dr. Moxley. I know that Mrs. Berenborg had to step out early, but she did have a couple of questions, and I believe Dr. Moxley was going to ask those on her behalf.
I do. Mrs. Berenborg has 2 questions for Aon, and one is referencing page 12, but I don't think you talked about this, and this has to do with pharmacy. You mentioned that joining with other groups with regards to pharmaceutical expenses can help decrease prescription costs. Can that be done with, like, the various agencies we have in this room, even though there's different plans? But, I mean, is there, and I'm assuming from her question, what I'm now comprehending is that we may all have different plans and different systems, but can agencies come together for a piece like pharmaceuticals to increase your pool of people, obviously, to get a better group pricing?
Yes.
And
the reason is.
And how does that go about? How would we go about even thinking or possibly exploring that?
Sure. So you can come together as different entities here today and go to the marketplace with, instead of 1,800 households here and 1,600 households there and maybe 500 households at the city, not quite sure the exact demographics, and come as a 5,000 life group when you add it all together, whatever the numbers may be. And with that, you tend to get better attention and better pricing and better ability to negotiate deeper discounts and bigger rebates. Now, as part of that, obviously, if different benefit plans are important, you got to negotiate that up front, and then you got to figure out, likely you pay your own bill in terms of claims, but you may share the fixed costs and you may share the rebates in some different fashion, and you just get a better net pricing than you could if you did the contracting on your own. Now, there's models out there where firms like ours and our competitors bundle thousands of employees together and go to market, and that gets you even better pricing. But if it's more appropriate to do it within the entities here, that could be one step, and then you could look to ones that are statewide. There's school districts who band together. Yeah, there's different ways to kind of skin that cat.
Great, thank you. And the second question is referring to page 15. You talked about rewarding high-value behaviors and the target plan design and incentives to drive those high value. How are we awarding, or that's what I think she has here, rewarding high-value behaviors now in our plan. And I don't know whether that's Aon or
For the
Merity.
most part, that kind of speaks to the incentives we were talking about earlier on the CareHere slide.
Speaking to
We have many different things that we could be doing to reward different behaviors with our employees through wellness, through choosing appropriate physicians, so on and so forth. But until we get that wellness piece in place and that person on board, we just don't currently have anybody to do that, to pull all those pieces together. We could actually do like a gift card incentive for anybody that goes to CareHere and does their annual risk assessment. Until we have that body in our office to pull all these pieces together, we don't have those incentives. We have a lot of benefit through all of our vendors, not just Florida Blue or CareHere, but our life insurance company offers many little different pieces, like some free estate planning, will design, these types of things that we, as the benefits office, aren't fully aware of, let alone our employees. That's going to be part of what this wellness person is going to do, pulling all those already available pieces, free pieces, together and educating our employees. So once we get there, we can certainly have challenges or incentives for doing an annual risk assessment or incentives for going to a lower cost provider.
Thank you very much. And just two comments from me. One, I appreciated the wellness component that you shared, Suzanne and Jason, because I do think that is an area of growth for us that we can help drive those costs down, and I think you have a good model in place. And then Chairman Zork, when it's appropriate, we did get a handout that talks about costs, savings, and cost savings for the employee, as well as cost avoidances from CareHere. That may be of interest to the participants with that.
Did you have any questions yourself?
I don't have any other questions. Thank you. Mhm.
Mr. Fagan, did you have any questions?
No, ma'am. No questions this time.
All right. Dr. Shuff?
Sort of a statement leading into questions. What I'm hearing in both the presentations and our conversation is there's two different pathways of this, and one is a philosophical issue and one is a practical issue. So philosophically, how do we want to go about our healthcare plans? And part of that, what I hear in some of this, and I've heard it come out in conversations about pharmaceuticals and other things, is part of the challenge in this is integrating and shifting our roles from being both a recipient of services but also an advocate for how do we change this, right? We are stuck in a dilemma where healthcare costs escalate and we feel like we can't do anything. It's a federal issue, or it's happening elsewhere, or it's bigger than we can manage. And part of our job here, I think, is understanding and shifting our role. And I hear this, and without going into details, I've heard this in some, your comment about wellness, your comments about coming together. I'm leading into a practical question, which is related to Mrs. Barenborg's comment about pulling together, right? How we do that, which then philosophically shifts who we are in response to health, big pharma, or sorry, I'm still on Blue Cross Blue Shield too, or Florida, like, without us, they can't do what they do, right? So we need to also be cognizant of not just the practical services we provide and how we do that, but how we shift our role from simply accepting that, they're, as Jason mentioned, they're not providing information, or they're saying, well, this is just the cost. Well, it's not. It is to a point, but if we are not advocates for how we accept or don't accept certain of what we consider to be givens and simply passively receive that, then we're missing a huge element of how we do healthcare and how we respond as consumers in a market-driven economy, right? So part of it is that. Should I stop before I go into part B? And then within that, as came up in the pharmaceuticals, but I think it's bigger than just how do we band together as a countywide or statewide unit in our collective power. And this is, I'm going to reference, this has come up before in my conversations with school board members, but not for the broader audience. I'm a member, I teach at Florida Atlantic University. I'm a member of a statewide university system that has thousands and thousands of employees. Therefore, the costs are, I never realized what good health insurance I had until I started having these conversations. My health insurance premium, some of my out-of-pocket costs have shifted, but my premiums have actually not changed in, 20 years. And they are dramatically lower than anything that I've heard either in district insurance or in county insurance. Part of that is because of the bulk of buying power, right? So how do we do that either as a county or as government institutions or as school districts? The challenge I know is that comes into a collective bargaining issue. So somehow that has to be integrated into how do we work that with our respective collective bargaining entities? Because we have power in this as a larger entity, as a school district, as a county, as a city, we have very limited power, right? But when we start marshaling those together, so what I'm curious about is how do we do that? How do we do that? How do we work with our collective bargaining units, but create the best bang for our buck in what has been cited in this conversation and others as some of our fastest growing costs. And that cost gets passed off to our employees in ways that are increasingly challenging. You know, I as a board member am really challenged by having to keep passing those costs to our district employees, which gets to happy employees, right? You know. So how do we do that? How do we come together to make sure we are getting the best services and I don't know, what's together, goods and services by marshaling our collective power together? How do we do that? To me, that's kind of at the essence of this conversation. Because it's not just, you know, are we comparing this hospital and this hospital? Or are we comparing this plan and that plan? It's a much bigger issue than that. And I think we have some power in that if we choose to use it as advocates rather than just as recipients. So I'm tossing that out for
Jeff,
anybody.
would Aon like to try to tackle that question?
It's a little big, but.
Would you like the universal response?
Any experience in other groups that you've worked with?
I'll address it in one. So in like consortiums where you have a larger employer base, that obviously, because of leverage and how you access products and services, affects that. Right. I'm just going to toss out a couple things we need to keep in mind when you talk about employee end cost. So we talked a little bit about if different entities operate differently and they have different cost structures, and that's obviously in a collective perspective, it's a different cost structure. County governments have a different budget and cost structure, and just in terms of financials, than does the school board. And then when you factor in, so in other words, what's the top line? What bucket of money are we dealing with, and how do we dole it out? And then what's our contribution on behalf of that towards the employees, which affects that out-of-pocket cost. When you see it, there are just different factors that affect it before you see what your premium is. I'm kind of tossing that out there just from a financial perspective, because there are just differences between state level, county level, school board level in terms of the budget and how they divide that cost. So I'm just tossing that out from a financial perspective, because if you start to look at plan design Richmond, how rich the plan design is, how many tiers there are, how many plans you have, what the contribution is, you know, for each tier. These are just different levers that you pull that affect what you're going to see at the end of the day. So that's more just a comment to that, not necessarily how we fix it. When you talk about bringing people together, I've dealt with a lot of entities that have tried to do the multi-employer route, which just is kind of fraught with issues in terms of how you actually deal with that. We had association health plans that didn't actually take off and wish that they would, but the carriers weren't there as well. So my only real response that I think might fly a little bit in the face with Paul in terms of what happens with respect to pharmaceuticals and whether it's 2020 or not is that what you do see, what is a business reality, is that when you change the game plan, so when you're talking about being an advocate, when you change that, they will react, which is why hospitals put up urgent care, is why they put up billboards, because the population changed, the business model changed, and people were then aware that there's a lower cost way to go. We've seen it in all kinds of industries, and that's why exchanges came about, because there are the Amazons of the world that change how you buy things. So I do think that there will be an effect on and I'm just going to speak pharmaceutical for a second in terms of the international piece. If the FDA gets on board and big lobbies don't kill it, because there's going to be a different alternative for the same medication and prices will go down because there's competition. If that goes through, and that's the big if, and that's why I'm more optimistic than Paul is, but he's the actuary, so that's why we have him here. So that's one piece of what we can do. How do we drive costs down? But the other is there's going to be a way, and I do believe that there's going to be a big move towards the services that direct employees to care. So I'm not beating the navigation drum too loudly, but even the carriers have seen it where they're really just down to the network because they're not doing the other services, because you have someone that's going to drive you to the lowest cost care. When that ramps up, that's going to change the way things are priced, and that's going to eventually have an effect. But I don't know that it's a banding employers together as much as changed the way we operate in procuring, communicating, and mobilizing our employees to procure care. That's my soapbox. It's hard to implement, but
I'm glad I'm not the only one having a soapbox moment, so thank you.
We've done that to a small degree, just taking our leverage as one of Indian River County's large employers. We have gone out to Indian River Radiology, and we now have an agreement with them that if an employee is prescribed any kind of imaging services through our clinic, the employee goes to Indian River Radiology and they pay zero copay. So some of these imaging services can be $100, $300, $500. So it's a savings for the employee. It is not going through our plan, so it's not claims against our experience. And we're paying, I think our agreement with them was 7% over Medicare rates. So that's a lot less than what we would pay through Florida Blue.
Under.
7% under Medicare rates, sorry.
How does that work now that Vera Radiology is owned by the hospital?
It's Indian River Radiology.
We're with
Oh,
Indian River.
Oh, not Vera Radiology, okay.
So there's one of those small pieces that we can do.
And
That's good.
A lot of those relationships, when you can create them in the community, you'll have, even if you have an on-site health center, or even if you don't, where there are certain cardiologists, pediatricians, they're feeling this too. They're feeling all the changes with insurance, and so they're also looking at ways to be reimbursed much easier than clicking all these codes and having them rejected and waiting so long for their reimbursement. So there's a lot of groups out there that are willing to direct contract. Typically, it's a little easier if there's a health center involved and you can look at the health plan data and make that educated decision on how much that's actually going to save. But typically, even groups that don't have on-site employer health care have that ability to negotiate as well.
Well,
Dr.
Schiff,
and-
did you have a follow-up?
Yeah, one of the, in addition to international pharmaceuticals, there's also, medical travel, right? You can get things so much cheaper out of the country. Medical tourism, yeah. I wound up going out of the country for a root canal that cost me less than half of what it cost me by what was recommended to me by, my dentist and oral surgeon, including a hotel overnight, including airfare, including food. It was still less than half the cost. So there's all these, it was kind of remarkable. So there's all these ways that, you know, if they can do it, why can't we, right? I know those are larger issues than we can approach here. One of the things I didn't hear Suzanne or Jason say was the cost of your policies, and I know you have different policies than we do. So I'm curious about what the cost is, how that compares to ours. We may not be able to have that conversation now, but it may be a conversation for our representatives and yours to get together to see if they are comparably priced for comparable services. And if they're not, why not? And how do we bring those, how do we effectively negotiate one of ours, you know, whichever is higher down?
When you say costs,
The cost to the employee of the insurance and the cost to the county for the portion that they're contributing.
so when we meet with our actuary and they provide us their recommended funding for the next year, it's in a different manner than what we actually show as our monthly premium. So we kind of back into it. You take you're going to need this much funding, this is how many lives, this is per member per month cost, then you add on all your fees, and this is the net result. Then we look at our enrollment, and we have single coverage, and then we have family coverage. We only have 2 tiers. We've done that intentionally because we need, it was important to us for our recruitment purposes and making family coverage very affordable. So our premiums for our plans going into the upcoming plan year for the silver program, the monthly premium is $675 a month, and the family premium is $1,232.50 a month. Out of that, the county pays $660 a month for single coverage.
Oh, wow. So wait a minute, the employee is paying 15?
If under the silver plan, they'll pay $15 a month
For single.
coverage.
Wait, I'm sorry. I'm sorry.
Yeah, you heard that
So
right.
single
Who's the
coverage
boss?
is $675. This is the silver plan. This is the lower,
Yep.
more affordable plan for the employee,
Right,
okay?
$675 per employee.
For the single coverage,
For the single.
the county will pay $660 a month. The employee will pay $15. It's a 70-30 plan. It has higher deductibles and co-insurance than our gold plan. So the deductible under the silver is $800 single, $1,600 family,
What does the county pay on the family plan?
$1,025. Now,
We'll
that's
get
a
you copies
fixed
of
cost
this.
for whether you go to the silver or go to the gold. So the county says, this is what we'll contribute. As an employee, if I want to enroll in the silver plan and have a very low monthly premium, I can do so, but it is less coverage. Then if we go to the gold plan, the total monthly cost is $745. The employee will pay $85 a month for single coverage, and family coverage will be $1,375 is the total premium, and the employee will pay $350. Now, that is more than what our employees are paying today. Employees today are paying $50 for single coverage under the gold plan, and $267.50 for family coverage a month.
Because they're grandfathered in, new employees come in at the higher rate?
Everybody's changing effective October 1.
Got it, it's going up,
And
I
then they
see.
get to choose. And the reason we
Right.
did that is because our funding requirements were going to be so much higher, we wanted employees to not feel like you're going to have to pay this new money out of your take-home pay. If they didn't want to do that and wanted to save a little bit, they can go to the silver. The sheriff's office just completed their open enrollment, and the majority of folks enrolled in the gold plan and kept that level of coverage. So they could have chosen to go silver, which some of them may have. I expect a little bit more of our millennials to go silver, just because they're indestructible and they only want to pay their $15 as opposed to $85 out of their pay. But, you know, at the end of the day, we'll end up where and see where
And I'm
everybody
sorry,
ends up.
I think you said this, how many employees do you have?
It's like over 1,600 total insured, about 328 of those are retirees, and then over 3,600 lives.
Meaning those covered by family plans who are not the actual insured.
Right.
Okay.
Right. And the other thing to note is, and this is Commissioner Zork, the difference. Your health plan experience is unique to you. And you cannot benchmark against really somebody else. I mean, it's a benchmark, but it could be a completely different demographic than what your group has. For us, we have a very high retiree population. Sheriff's Office had a discussion with their group, your sheriff's group. And the broker that you were talking with is like, wow, that's a really high number of retirees on your plan. That's our reality. We have a large number of retirees. Now, that number is going to shrink over time because the health insurance subsidy that the county is providing at a point in time, it was not continued. So if a retiree wants to continue on the group plan, they're going to be paying the full premium and not have it subsidized by the counties. But we do have the folks who are out there. We have for law enforcement and for emergency services, 25 and out? So at 25 and out. So if you're going in at age 20 and you're going into emergency services or law enforcement, 25 years later, you're retiring, and then you have to have coverage to carry you through to Medicare eligibility, 65. So some people will choose to stay on our plan because it's probably going to be less than what it's going to cost them to go to the marketplace as a retiree with family coverage. But, we'll have to deal with that. Our unique experience is we had 40-some high-cost claimants on our plan. We had some infants that were born with some serious conditions. We didn't hit the $1 million mark yet, but that could be our experience next year. We could have the $1 million baby, the $2, $3, $4 million twins. You just don't know. So we also have high-cost pharmacy claimants, medications that for a single medication are costing the plan over $600,000 a year for one medication. The member who has the family member who has the medication, the rate increased to $350. They said bargain, bargain, because they're utilizing the benefit. So it's not apples. You can't compare your plan to our plan. We're going to design a little bit different to make it meet our needs for our group. I noticed that you had your PCP and your specialty visits were both 25. Is that true on one of your plans?
On our high plan, not.
On the high plan. So ours, it's, I think 25 and 50 or 30, 25, what is it? 45, yeah. 25 and 45 on the high plan. We still have the distinction. So it's, and then the silver plan is going to be up from that.
And so, yeah, to the overall cost, I'd say the size of our plans is pretty close. You have more employees according to page 9, I think.
Right.
Of there, you're averaging about 1,800 employees or subscribers and about 3,500 members. We are about 1,650 subscribers, which includes probably a larger I don't know what your retiree population is, but ours is probably larger, and our members is about 3,600. So, and to the question of the difference, to Commissioner Zork's question, the difference, some of that is because our past experience, it's about $18.8 million this year, and it's also with one plan. And the school district has the 3 plans, and I don't know what your mix is between your high, medium, and low, but and it's hard to compare apples to apples, but I'd say the current plan that we have that will be our gold plan is probably most comparable to your high plan. So when you've got folks, if you've got a certain number of your folks are in the medium or low, fewer of those costs are going to be hitting the plan, and more are going to be borne by the employees, so they just wouldn't happen. And it's hard to compare apples to apples because, for instance, our deductible for the gold and the silver is lower than your deductible for your high plan, but then we've got a higher copay for specialist office visits, so it's always hard to compare. There's hardly do you ever find one that's exactly the same as you. So you're always comparing apples and oranges.
And then one of the challenges for, everybody getting on the same plan is the needs are different. The needs and what people want from an employer perspective, they want the employer to, I believe they want, keep the disruption as minimal as possible and talk through change. And that's really hard to do when you're in a big group, because then everybody's perspective of what their needs are is different.
We are going to move on. We have 15 minutes. I know the HITAF member, I'm going to come to you, Mrs. Rosario. The HITAF members, did anyone have questions back there? Mrs. Cannon, you want to come on over here and sit down, and then after Mrs. Rosario asked her questions, we'll let the HITAF. I'm assuming that you have a lot of questions. Go ahead, Mrs. Rosario.
I just, within the few minutes that I have, I want to just start real quick before we forget to thank Mrs. Zork for putting this together. This really was her baby. Although we are hosting it as a district, we are supporting the vision that Mrs. Zork had in having this discussion at a very needed time, moving into a new school year and open enrollment period and so on and so forth. And as a new board member, this is very important for me because I've never needed to pay attention to some of these policies and procedures and so on and so forth. So it's important, and I wanted to thank you for doing this, and it's a pleasure to stand behind you in this vision and us at the school board level. Some people might say that, and I've heard this discussion, that a school board, that we are not in the medical business, that we are in the educational business, and that we should stay away from anything that has to deal with medical stuff. I will differ on that opinion for some people who have that, because at the end of the day, it's not about negotiating with unions. It's about negotiating the lives of human beings and our employees who will eventually service our children, who will eventually receive high-quality education, and moving up will eventually have happier, healthier families and become, effective citizens of our community, really. I guess that's the slightly political answer, but we just want healthy people and we want happy people. That's my view. One aspect of the human resources part of our job is to ensure that that the medical side of the human resources component of a school district services our people, our employees, the best way possible. Not moving off of this topic at all, for some who may not know, my husband is a sheriff deputy in St. Lucie County. So we fall under his plan as St. Lucie County employee. Their medical benefits include CareHere for St. Lucie County. And they also have, and I might just share a little that some may not know, it's my understanding that all county employees in St. Lucie County have the CareHere network plan of whatever that might be. So the benefit of that is, there are so many benefits to it for us as a family. One of the things that Mr. Zork mentioned earlier was on that Sunday night, 7 p.m., the child has an ear infection. We actually faced that recently. And my son did have an ear infection, and we couldn't get to a doctor. We did not want to go to an ER, or an urgent care facility. And so one of those benefits of this medical plan that St. Lucie County employees have is a online doctor, which was weird for me. And so he made this, set it up, whatever it was, and of course, I'm like, really? Like, how they can't do the ear, you know, you need to look inside of the ear, you know? Like an ENT would with that little scope thing. Well, I don't know what they did. They did it, they asked questions, they facilitated it all via online, and, an ear drop was prescribed temporarily until my son can get to his ENT appointment, which was just a few days later. I called the ENT, we went in, it would have been the same exact ear drop that the ENT would have prescribed for my son. And it cost us nothing. It cost absolutely nothing for this to happen. We didn't even have to leave the house, which was, other than going to pick up the ear drops. In addition to that, because we live here, and this is St. Lucie County, my husband and I, we drive to the Fort Pierce CareHere facility there, and we can actually access CareHere services throughout any of their locations in St. Lucie. So looking at what we offer in comparison to what St. Lucie offers, the benefits of having CareHere is, from my view, is incredible, because we don't have to pay, we don't have to make an extra visit to a pharmacy. It's that one stop, you go in, unlimited amounts of visits, you see a doctor, you come out with full service and your medications, and you just go straight home. And you pay nothing, absolutely nothing. So some may ask, well, there had to be a cost somewhere for CareHere. I wasn't here in the district when all of this kind of happened, so I don't have history to compare what was the premium for the employee versus what we have now as a premium for the employee. But our premiums on the high plan that we have, since we were just talking about the gold, your gold, and then our high plan. The premiums for the high plan, for any of our employees, is that these premiums already include CareHere services. So there isn't an additional cost. The employee who wants to choose a $12 plan for just the single employee on the low plan still has access to CareHere. And the family on the high plan still has access to CareHere with no copays, no extra out-of-pocket expenses, no extra visit to Quest Diagnostics for labs, no anything, no extra pharmaceutical visits, as I mentioned before. In St. Lucie, some of their clinics include mammograms. Some of their clinics include some of those high, I think they're working on an MRI special plan. Don't quote me on that, I'm not really sure. So we don't have to be worried about a $1,000 pharmacy charge for an extra copay of a medicine that we can't afford. I find that incredibly beneficial for us. And I've heard from multiple employees in Indian River County that it is an incredible benefit for them as well. I've also, I know I might sound like I'm a little all over the place because I have so many notes here, but I've also been wondering about the benefits of combining efforts, right? Combining all county employees on a single plan for this bulk service where you all have a gold plan that costs your family $350. Our high plan is $435.
I think that's biweekly. Ours is monthly.
Okay.
That's correct.
Ours is per pay period, ma'am.
For ours is, okay, so upwards of $800 for us, right, for the high plan. Yours is $350, but ours, and I'm not justifying our $800, but ours includes the CareHere and some of these other benefits that yours does not, right? So you have the high copay, you might have the higher deductible, you might have some of these higher fees, maybe, that your employees would probably have to incur, maybe the high prescription meds that are not included in there, we do not have to pay. But I think that if we were to consider what it would look like in a bulk county effort, I think it would, I just want to assume that it's going to benefit everybody, that everyone will have, our employees are not going to have an $800, hopefully, an $800 on the high plan fee. We can kind of leverage that out so that, people aren't paying an arm and a leg for medical services. When combined, what is it, over 6,000 employees, if we were to look, that's on average between all York County, Indian River School District, retirees. So why not? Just throwing it out there, why not try to have these conversations? I know the question there would be, and it's probably very, at this point, minute to even throw it out there and discuss it at this point, but at some point it would be who would be responsible then to be that because there's got to be someone who's going to be responsible at that point for making decisions and then tiering that out. But I just think that it's something that we all need to really consider. I really do. I had a question for CareHere, so here we go with the question. What was the initial cost? What is or was the initial cost for setup? Because I know you said that there was an initial cost originally. Do we have a number for that?
We just have a rough estimate. Diana, do you want to speak a little bit to the rough estimate?
So I can speak more to our current cost versus our prior cost. I was not with CareHere when the center was open, but I know that there were a lot of costs that went directly to the school district. The school district had to purchase a building for the center. My understanding is they did not already have that building. But we have clients who already have buildings, and we form what we're doing to fit what they have available. It's kind of a hard number to come up with, but our current cost.
We can get that for you. For some reason, I'm thinking it was around 150 startup cost, but was that right?
We were actually working.
50,000?
We've been working on going back through the old invoicing. The school district, of course, as I said, they have some that they paid directly themselves, so they would have to provide that information to come up with a total, what the cost was.
We're currently working on that number.
So if we were to, hypothetically, if we were to combine in this effort and need a new facility, for example, is that an approximate what a new facility might cost? 150,000 approximate, more or less? No.
No, you're 4 years out, so costs have gone up on everything.
So more.
Again, we had a building, we no longer have an empty building that I know of that we could use, so we'd be purchasing a building or a trailer or something on top of that, so it's not a good number to be planning on right now.
There's a lot of variables there.
Okay. I just wanted to, because the more participants you have in this, obviously, the more you're going to need probably another facility later on down the line and more doctors and nurses to be available. I know St. Lucie has their services 7 days a week. So on a Sunday, we can go to a CareHere facility And it has lessened, it really has lessened the amount of your traditional doctor visit, right? So we had that little circle up there that said the number of visits equals the number of ER. For our household, it really has lessened that ratio. Other than a specialist, maybe. So I think that it is definitely something worth considering, moving in that direction. Has the county considered CareHere at any point?
I don't know if they considered CareHere, but you guys looked at, before I came to Indian River County, we looked at having an on-site clinic.
Right. Many years ago, we looked at potentially establishing a health clinic. It may have been with CareHere. There was a WeCare and a CareHere. We looked at it. We actually looked at possibly partnering with the city of Vero at the time, and the board decided not to move forward with that. I will say we had a significant objection from the medical community, even though the folks that our broker and the clinic company that we were talking to said you can hire a professional they would hire a professional from the area so as to not be a concern about competition. Boy, we faced it. It was also characterized by some opponents as special privileged government employee care that nobody else could get, and that became deadly for us. It was like something that we were giving to ourselves that the taxpaying public couldn't get.
Free care.
Yeah, free care because of the no copay. Because it was a similar model. You drive usage there because there's no copay there, and it's going to cost you $25 to go to a primary care physician. We had looked at partnering with the city of Vero, which, back to the point of going together in a consortium, that complicated things. That wasn't the only problem, but it made things more complex. So whenever you're dealing with multiple entities, you run into more challenges. The thought was kind of at the time with more, you could have more hours or more locations or more professionals, more services. But I can tell you the board decided not to at that time. When we were talking about our plan changes a couple months ago for next year, the topic did come up, so we'll probably look at this in the next year. I can say there's some hesitance on my part based on the experience that we had last time. I don't know that it's not something to do, but we decided against it. I'd say it's probably 8 or 10 years ago.
And we'd also have to consider in taking on that expense of a clinic, what's the return that we're going to get? Is it going to give us a return on investment? What type of utilization could we expect? And our challenges are our employees don't all live here, and our retirees don't all live here. It's pretty spread out. So and the overhead of, we could have potentially one location for a group of our size that would make sense, but are you going to be able to get the utilization for this to pay for itself and bend the curve down to where it actually improved your plan performance?
Well,
Okay, hold on one second. We're
this is a
4
follow-up.
minutes. Okay, just a second. We're 4 minutes over. I know that the high TAF had a few questions, so we'll, where we were running 10 minutes early, now we're probably going to be running 15 minutes behind.
If I may,
Just
Mrs.
as a
Zork, on
follow-up.
the same subject, we have literally closed our clinic for the tour time, so we need to be time sensitive to that because we have appointments outside of that. And while we're talking dollars and cents, we're paying for that time. It's going to cost us money no matter what. So we certainly don't want to
So
inconvenience.
we have that at 1 to 2.
Yes,
We're-
ma'am.
Okay.
I just have a follow-up there. As I mentioned before, I can see some of the concerns that you had back then, but, things have changed.
Oh, yeah,
I would venture out to say that some in the medical community might consider this competition because, they want us to be in the office. They want us to go to a traditional doctor's office. I get it. But if it helps us have healthier, happier employees, people in our community, it doesn't really matter to me. I just, what's better for the employee and the person is really my priority. Now, last question. In the groups that are included in the county, I see BOCC, Sheriff's Office, Tax Collector, Clerk of County, Property Appraiser, and Supervisor of Election. Is there anyone else that's a county employee, essentially, that is not only us?
Just retirees.
And school board, right?
School board is not on our plan.
I know, but we're on our.
Oh, you have the health department,
Their state of
their
Florida.
state.
Their state.
And
City of
Another
Vero
county.
Beach.
Jason?
And your municipalities.
Yeah.
City of Vero Beach, remember?
City of Vero Beach is not,
There's
okay.
a little town out west, Fellsmere.
Fellsmere,
Indian River Shores.
India, okay.
They're all
Okay, so there's still
employers.
potentially other municipalities that, if we were discussing bulk, that might be interested in possibly joining that pool, raising the amount of insurers, not just 6,000, whatever else it might be, maybe 6,500 or something like that. Because we know that the more, as Aon mentioned before, the more members, the more employees you have who are participants, the less your premiums may be in bulk.
Could be, depends.
Possibly.
Yeah, I'm not, and let me just clarify if I can. I'm not sure bulk drives down claims. It drives down fixed cost.
Yeah.
And it may improve claim discounts or rebates or pricing terms, but the claims will be the claims by entity. It's just some of the fixed costs that can either get amortized over a bigger group, or you can strike a better deal because you're a bigger group going to the carrier or the vendor,
Correct.
right?
Very similar to the state where Dr. Schiff has that experience where there are thousands of employees and, of course, her premium hasn't changed in 20 years.
We're gonna, if you'll pass your
Yes.
mic over.
Sorry.
Okay, there.
Thank you.
Good afternoon. I'm Liz Cannon. I'm the president of the Teachers Union and part of ITEF. I'll be very quick. Most of my questions were already answered. When you said that you guys participate in an international prescription provider, who is that provider?
It's through CanaRx.
And how we did participate with CanaRx. How did you deal with the lack of ability to follow HIPAA or comply with HIPAA? They won't commit to compliance,
So,
HIPAA compliance.
We don't transmit any information from our plan to them. We don't transmit PHI from the plan to CanaRx.
But-
CanaRx communicates with the member and CanaRx. So it isn't us communicating with CanaRx. There is no HIPAA requirement because we're not sending them anything.
But the employees are potentially
The employees
subject
are
to.
voluntarily
Yeah.
enrolling in a program, giving them a prescription, and then they are taking that prescription and working through another pharmacist to have that prescription filled at an international pharmacy.
And have you followed up on the potential cost savings of such a plan, or?
So yes, and I don't have those exact numbers. The enrollment isn't very high. The medication is very limited. It's a limited list. $283,000 is about an annual cost savings based on the medication enrollment.
Okay. And then I had a question for Aon. When you were talking before about comparing, for the comparisons of the providers, how is it that you determine quality in a provider? Because I know that we've faced this issue before. We had a healthcare blue book, and we were told one thing and received another. So I would love, determining quality of your provider is one of the most important things for our members. So that's something that I just find very important.
So feel jump in, Jeff. For hospital providers, the vendors that we're engaging right now are looking at different metrics around readmission rates, lengths of stay, infection rates, some of that hard data that they can actually capture. It's a little bit more difficult to get quality around doctors. That's a little harder to measure because they don't have as much a pool of data, and some of it is, how the patient feels about the experience. But around the hospitals, it's really a lot about the outcomes, some of those stats that I just mentioned.
So basically, it's the same information we got from Healthcare Blue Book, but it just doesn't cost us more money. Is that correct?
I'm assuming it's similar data?
Yes, okay. Okay. And Florida Blue does have, through their website, and this is where educating your members comes in so handy because their website is amazing. It's just a matter of time going into it. And also to respond to your question about the clinic, over the 5 years since we've had the clinic, we had a -1 trend in medical claims. So that in itself, while I believe somebody had stated before that nationally it's an 8% trend, -1 trend for 5 years. So there is a direct correlation between our clinic presence and that reduction in claims. So I just did want to point that out. Did I forget anything? By the way, Gary Kronbacher and Ren Robb also of the High Tech Committee.
Okay. Well, thank you. Is it something that you can ask after?
Yeah, I just wanted, is there any county government school boards in Florida currently doing a joint program that you guys know of? Then you can tell me afterwards if you know.
Tell
I
him
think St.
afterwards.
Lucie, I think.
And if I could just follow up on that, another possible consortium is not necessarily school board and county, but maybe it's school districts. I don't know if that's possible. I don't know if school districts as an entity in the similar way that university systems do that can create consortiums.
Okay. Well, this is a good conversation. Unfortunately, we're in
Overtime.
We've been here a few hours, and I think it's a good conversation, and we could keep the dialogue going. I did learn quite a few tips from the county that I heard, and some others that I cued in on. And I'll follow up with you guys to get my questions answered. At this time, like you heard, I do have something in the break room for everyone that's here, if you want to make your way through the break room. And then the address to the CareHere clinic is right here, and I really encourage everyone that has been thinking about a clinic or would like to see what it looks like, and also our staff and our board to take a look at it. And
I just, last clarity, that the clinic is not an emergency room or an urgent care. I just want, for those who hear the word clinic, you may interpret that to be an emergency room or an urgent care facility. It is not that. It is considered a medical facility, a primary care facility where you can establish the doctor there to be your primary care physician.
Thank you for that
I want to
clarification. It's
thank
helpful.
Very important.
everyone who came out and attended, and our presenters today, and I thank staff for helping behind the scenes make this run very smoothly, and the guys over in the sound room. So at this time, we're going to adjourn at 12:44. Thank you, everyone.